This conference will now be recorded.
Hello, there is no voice. We cannot hear. Dina. Dr. Safia, no voice. We cannot hear you.
No voice.
Dr. Satya, we cannot hear you.
No, radical examination is different in a way that it actually examined you, not audible. Okay, voice to the problem. Is it any better now? Okay, can somebody give me some answer? Can you hear me now?
Yes,
No
ma'am.
voice, still no voice.
Yes, yes, yes.
Okay, let's put the speakers that I might be able to bring you better. Okay, am I audible now?
Yes, yes.
Yeah, all right, okay. Right, so okay, so start again then. Good day for everyone and welcome to this session. I hope you will find it helpful after spending 2 or 3 hours this morning with me. So this is continuation of the previous session as we did. So I'm just trying to make it easier and help our candidates who want to take MRCG Part 3 to understand how basically you get an idea what is the theme of the station and how that should be approached. Very simple, again, just a routine, your routine styles. You do that, every day in your clinics, in your theaters, in conversation with your colleagues. So just to become a bit more organized and structured, basically to complete those tasks within 10 minutes. So we did cover. So it's just like, so just further add a little bit more. The part 3 is different from routine or other standard examinations as we do. It's not only theoretical assessment of your knowledge. There is obviously some aspect of theoretical knowledge assessment as well, but there is a lot more. Major chunk of this assessment is basically to, assess your behavior and different aspects of your role you will have as a working consultant in NHS in Obs and Gynae. So yeah, so just try to prepare in a bit smart way rather than working too hard and still not clear and organized what to do. Um, Active participation. This exam, the trick to pass this is that you must actually speak yourself. So all the courses and the practice you're doing, please be active members. Being listener is really not quite helpful, because when you're listening in your head, it feels like, yes, I know I'm going to say that this way, this way, this way. But when it comes to basically pronounce that and bring it out and perform within 10 minutes, it just simply doesn't happen. So you need to rehearse in a way that make your points, be organized, and then how you're going to do that whenever you're doing the practice, even in your it's important to participate whenever, whichever the course you are doing, as a active participant, because that also take your hesitation away, the bit of fear of anxiety. There's a major part of exam as well. Some people just freeze under stress. So all these preparatory courses give you an opportunity basically to address and beat that fear as well. So your body becomes used to say, okay, right, I'm aware of, I'm familiar with this stress already, and I can deal with it. And these are like kind of, I call them human factors. They are really important. Yeah. So practice, practice, and practice. You have to, say every station many times, record them in 10 minutes, listen your recording, see if you have covered everything in 10 minutes, not start again and then record it all again. Okay. So yeah, so just a bit of overview to catch up. So what are you being assessed and examined in this exam? These are like the very standard 4 domains. General medical counsel assess us anyways as well. every year we do that in our appraisals, and we give the evidence and reflect like that we are actually in compliance with these domains. So one is about clinical knowledge, communication, and communication in turn then has two parts: communication with patients and with the colleagues. Safety and quality improvement is the third main pillar, and teaching and supervision. These are your roles basically you will be doing as a doctor in this country. Well, everywhere you do that. So we did cover clinical knowledge last time, different aspects, how clinical knowledge, how you will express the clinical knowledge in the exam circumstances. We went through different scenarios, how you should approach your communication. Then we did about the communication with patients as well under different scenarios like clinical circumstances, how you speak to your patients when you see them in outpatient clinic, how you open up and approach your patients when they are your inpatients and they are quite unwell or in emergencies, what you're supposed to do. So hopefully you all have those recordings. I tried to share them as much in different groups as I could do. Feel free to share these free recordings, among anybody. There's no copyrights on this, it's free. Okay, so we left with, we did cover all our communication with the patient, how we're going to do, and then we're supposed to do communication with colleagues, and how that communication with the colleague will be assessed in the examination, what type of scenarios and what should be the approach. So again, with the colleagues, if you try to think about again of your one whole day, or maybe more broadly speaking, 1 week of your work on the ward, in the theaters, and with your colleagues, that's what is communication with colleagues as well. So there are 3-4 different main aspects you can categorize how we communicate with. One is pure clinical communications, yeah. And these are like, we do handovers, how we actually hand over the care of the patient to our colleagues. In exam, you get that in the form of sometimes they give you a handover of labor ward in the morning, and how you should be doing and what you should be keeping in mind at that stage. Then some scenarios appear like as a, again, discussion with your supervisor or with a consultant or some other colleague regarding the pre-planning of your theater list for tomorrow. So what basically is the purpose, what you keep in mind, and why that is important, why we need to discuss or think about our gynae list for tomorrow a night beforehand. Then there are simple, sometimes we do talk to our other colleagues because we want to have a second opinion, or we come across sometime we're not very much clear what we should really do with this patient. And how we should approach and what. So that usually appear as a discussion about structured discussion stations. So we will just briefly go through that. A structured discussion, we did do that as a part of clinical knowledge as well. So we went through that, how that should be done when it appears in the exam. For those who haven't obviously attended the session, haven't heard our recording still, feel free to leave me a message on my WhatsApp number later on, and we will forward you the link. Then the second type of communication with the team is when we have some emergencies and unexpected situations. There are very certain ways how you should be communicating with your colleagues. And the reason why we need to practice them, the way we need to practice them is so that there is a kind of, again, standard behavior and standard pathways of communication under such emergency situations as well. So we do not actually miss anything. Yeah, we're so much rehearsed again in these that we just can just perform at that stage. So there's usually, again, some pathways and protocols we do follow in these situations, and we will go in a little bit of example for that later on. And then there is another very important aspect, which is not clinical, but very important for the safety and care of our colleagues, and also to ensure that they are safely performing and they are safe for the patients as well. And that's to keep an eye and also be aware of the well-being of our colleagues in different aspects. It can be their physical health, it can be their mental health. So physical health means if somebody is not really well, but still has appeared at work, and it's not unusual. We have seen that many times. The colleagues are really unwell. They might be having fever, cough, and whatever, and they're not really able to focus and concentrate on their work, and they should really be resting at home. But they still appear at work because they feel if they didn't, their workload will go to the colleagues, and they don't feel it as confident. But so that's the training part of your behavior as well, that you do approach that colleague and tell them, look, you really need to have the rest. You should be home, and don't worry, we can sort out the work here. Um, because it's important, yeah, for the health of that person, and also for the safety of the patients, and also to maintain the quality and safety of. So that can be about physical health. It could be about mental health, like some colleague you feel is not, usually there is some altered behavior they're having. They appear stressed. They were very chatty and very active, and cheerful type of colleagues, but they have suddenly gone be quiet, and they feel like they're not really here all the time. So that another thing for us to be a bit proactive and go and check on our colleague to say, are you okay? Is there anything you would like to discuss? From that point of view. So that usually covers, like, it can be undermining, bullying, those behaviors as well. So it's being having the awareness basically of all the aspects around us, just like as we do at our homes as a family members. So just a little bit, maybe a couple of examples of these communications, what we exactly meant. So communication with colleague, when we do some clinical communication, and I put the example, say, for example, this labor ward periodization appears in the exam, how we basically communicate with colleagues. So this communication is about transfer of care from one colleague to others. Yeah. So, somebody, team of colleagues has been on duty in the night or maybe during the day, and then how they should transfer that care to incoming colleagues. And they are standard pathways again developed for them to make sure what should be organized in structured way to basically make sure of transition of this care. And usually it appears in the exam point of view, it appears usually as a labor ward prioritization. And mostly people find it quite tricky when they are doing the examination. And they are lengthy stations basically from within 10 minutes point of view. So the time management probably is the issue. But if you follow again a structured way, then it's fine. So the handovers are done according to SBAR protocol, situation, background knowledge, assessment, review, or recommendations. So if the colleagues, they are also supposed to hand over this care to you on these headings. But for any reason, if they are tired, they're not quite at the moment 100% into them, and then you should follow that and make sure that you ask that particular information from them to make sure that you are fully aware of your patient to start your shift before you will be able to go and see them in detail later on when you do your ward round or your liver ward round. Now the way these boards appear, they are very typical, kind of, you can say, reflection of real examples. So it depends upon the hospital side. In smaller hospitals, you might have 7-8 delivery rooms. In bigger teaching hospitals, these delivery rooms can be up to 14-15 delivery rooms as well. And then very typical presentation as well. We all work in obs and gynae, and we know, yes, there is always 1 or 2 emergencies going on, some urgent patients waiting review, and then there are some which we can see later on. So this exercise is all about for you to be able to first recognize your priorities, what it should be. Second, able to be, you yourself cannot just go and do everything on your own. You should be able to, and you need to have that skill basically to be able to allocate the jobs to other colleagues as well, to tell me you can do this. So for that reason, you need to be aware of skills of your colleagues and team as well, how you're going to utilize them in a better way, so nothing is being compromised. Okay, so just a couple of these examples. I'm not going to do as a role player. They just take long time, hours and hours. So I can just give you a couple of examples here. So the way you're going to follow, say for example, we take the very first lady here. She's due for induction of labor at 39 weeks. She had ruptured membranes 24 hours ago. She's 31 years old. There is a lot given already. I don't know whether this all information really was given on the board, or it's just the person who later on reflected on the station they have added it. Usually the labor war board does not have this much of information, because that is just some bullet points there, we add up just to catch up that yes, this patient is there and these are the most significant, any risk factors and stuff. So in exam, basically when you will see these boards over there, they may not have all this information given already to you. They will simply maybe somebody waiting for 39 weeks, 31 years old, primi gravida or gravida 2 para 1, rupture membranes, yeah, tightenings. Usually this is how a little bit of information is given over there. The rest of the information, so for that reason, it's very important then that you follow S bar. Yeah, so the situation is what is given on the board already to you. Then the background information is very important. And obviously, mostly, your night colleague will verbally, give that information to you already by saying the rest of the information which is written over here. This is, we examined her last time in the 2 hours ago and she was this much of dilated. Blah blah blah, and then if she hasn't told something you will ask. But in the examination, obviously the examiner do not volunteer to give you the information, because they want to make sure you are aware and you know the importance of following this mnemonic of S bar, whether you are giving that over to the incoming team or you are taking over of the care from the outgoing team. So you must know that I need to actually ask these things. So background information will be in simple 2-3 questions. You don't need to go into a lot details in there. Simply it's the clinical and colleagues conversation. Yeah. So first of all, start, okay, whatever the scenario is given over there, then you can ask, okay, so start from the current information you need. Okay, rupture membrane, if say time is not given, you can ask how many hours ago, how long she has been contracting, is regular contraction, is she in active labor? Yeah, you will ask that question regarding about that. Is there any bleeding, and is there any fever she has, any other, tachycardia? So you can ask about these. What's her temperature, pulse, blood pressure, what's the color of the liquor, a CTG, how is the CTG, and then ask the examiner to give you CTG. Yeah, they will give you the CTG. And then you will say, okay, tell me about the contractions, how much she is, and when was she examined last time. These are the very basic information, just like as you will quickly ask the patient from history. Okay, just few important one again. Now the background information you need to know is, then in that one just ask two questions for the background information simply. Does she have any, maternal or fetal complications in this pregnancy? Has there been any concern about the maternal or the fetal well-being? And that is enough, because in front of you is your colleague, clinical colleague of almost your level. You don't need to ask about does she has high blood pressure, diabetes, this, VT. Just ask this one question. If there are any risk factors, she's supposed to tell you back then. Yeah. So you need to ask the examiner. Yeah. Is there any, maternal or the fetal complications in this pregnancy? Have there been any concerns about the well-being? And ask for the answer. Yeah. And then obviously then comes, okay, now is your assessment. How are you going to do? At this stage you will ask the examiner, can you please provide me the partogram and the CTG? And then you will obviously interpret according to whatever the way you want to do. As a rule of thumb, the inductions which are for low risk, again after, so say for example, take slightly different example, this woman is already tightening, maybe she's already in labor by the time you will get that information from your colleague. It could be something, a cold induction of labor sitting over there. So induction of, say for example, the 2 para 1, waiting for induction of labor are 37 weeks, and one stillbirth previously, waiting for induction of labor for IUGR. So by looking at this, is okay, it's induction of labor. I might have another patient with a major PPH going on, one imminent preeclampsia is sitting over there. There is one maybe ruptured uterus coming in through the ambulance or something, So my first intention will be, okay, this induction of labor, if she can wait safely, I'm not going to start this woman to add more, clinical emergencies in case. So we will try to hold on that work. But before I decide that, I need to make sure it is safe to delay that induction at this stage. Okay. So from that one, the scenario again, you need to have background information. So ask the examiner. Okay. So she has one stillbirth previously. What was the cause of stillbirth? Simple. So she's having this induction for IUGR. What is the reason of IUGR? Is she hypertensive? And if she is, what is her blood pressure? How is her urine protein? Does she have any symptoms? So if there is no imminent preeclampsia symptoms, say for example, if she was hypertensive, or if there is, so once you have made sure, yeah, there are, she has the risk factors, but they are well controlled at the moment, I will send one of my midwives to that room to speak to the woman and explain her the situation and the what, and make sure that she's satisfied from the fetal movements and put her on CTG to assure CTG is satisfactory. And we will wait and just say there can be a delay to start our induction. Yeah. So this is how you do. Then usually the third type of, and there will always be, because usually there is always some emergency in the labor ward going on. So say your room 3 here, she has a major PPH. Again, they have volunteered to give you every information here, but in the real scenario on the board, basically we don't have this much space. It's just a blackboard kind of thing, or a whiteboard, just just the few bullet points of important information are given over there. So the information probably you will have over there will be delivered 4 hours ago, PPH, blood loss 1500 mils. Maybe that's all the information you will have over on the board. So standard way to approach these ones is, again, protocol wise, you're supposed to, and you must say things in that way, right? So you will say, I recognize there's the emergency patient is a major PPH, so I will initiate the protocol of major PPH. It's important to say I will initiate the protocol of PPH or preeclampsia or car prolapse or shoulder dystocia, whatever the situation is. By saying that, basically you do 2 things. Number one, you are informing, you are making the examiner to be aware that you are aware that you will be managing this patient according to that protocol and that standard protocol steps, so that you won't miss anything. The second, it helps you basically in case if you're not able to say as much detailed things for the management, we will take it. Yes, you are aware. So the major, basically, what from examination point of view, this patient we want to hear at that stage. You don't need to worry about telling later on that, I will be giving carboparas this dose. If that didn't work, I will go to this dose. If that didn't work, I will go to this dose. And then after that, I will go for balloon. And then after that, I will give maybe, B-Lynch suture. And after this, we will do this and this and this. And then the blood loss, you start telling about the management as well. She will be given this crystalloid fluids first, and then we will be giving this, and then her coagulation profile. And when the fibrinogen level is this, we will give this. No, you're not supposed to say all that stuff at that stage. At this stage, again, because you are supposed to rush to start seeing this moment, you just need to give the outer framework, and the framework is immediately, I will initiate the protocol of major PPH, I will call for help, and will request my coordinator midwife or somebody else to call consultant obstetrician, consultant anesthetist, ST5 anesthetist, coordinator midwife, and any other staff member which is free to attend, because you obviously need maximum help here. I will approach the patient. I will start the assessment on ABC. To see if, we'll call the patient if she's responding, that means her airway is open and breathing. And I will ask one of my, so don't just keep saying, I will then do this, I will then do this, I will. No, you can't do all these things together. Your main role will be basically to start her, more technical assessment, like to try to find out what is causing the bleeding. So allocate these jobs to some of the colleagues. So you will say, I will ask one of my colleagues to attach the monitoring, pulse blood pressure monitor, and also the pulse oximetry. And if the oxygen saturations are low, we'll start on oxygen. And then I will ask one of my other colleagues to pass 2 whiteboard cannulas and just quickly take a blood for full blood count cross match and ask, request for the cross match blood and start crystalloid fluids. And then I will start examining. So this all will be happening at the same time. I will examine the women to see what is the source of bleeding. So first of all, obviously, you simply are going to approach from the abdomen to see if the uterus is well contracted. And at this stage, basically, you can ask. Okay, so you can say from here there can be two sources of this bleeding. One maybe atonic uterus, and the other one can be she might have been bleeding from that episiotomy. So then you can ask the patient, okay, so is the uterus well contracted? If the examiner doesn't tell you the only answer, then you say, okay, well, I will do that. And then because she has a large episiotomy being stitched, obviously vaginal examination will be difficult. If she has in lot of pain, and that will be compromised examination. So you will ask the anesthetist to top up the epidural, transfer movement preferably to theater in these particular circumstances, because you have a better light and everything to examine, to do for any tears, and then you can just roughly quickly say from atonic point of view, she's atonic, then you can just say ergometrin, symptometrin, syntocinon infusion. If that doesn't work, followed by, just name those, just name those, like carboplast, if that 5 doses. If that didn't work, then we will go to balloon, and if that didn't work, I hope my consultant will be there by that time. And depending upon the previous blood loss and the overall stability of the patient, you don't have to go take all the stepwise. If the patient is severely compromised, we might jump a couple of steps and go to the final step beforehand, says hysterectomy. So, and then you can say the fluid management, coagulation management, and there will be managed according to NICE guideline protocol. That's it. Go to your next patient. Okay. So sometimes what happens is, like, they shows you like few and there is usually the pattern is, in one the maternal life is at risk, and the some other room will be there the fetal life is at risk. So they obviously are the emergencies to get priority. And you need to be aware, again, usually there is some pathological CTG going on which need fetal blood sampling. Your ST2, from ST2 onward, people can do fetal blood sampling. Or they might show there is a bradycardia, but the fetal head is at +2, occipital anterior. You don't need to go there in the rooms yourself. If you have your ST2 or ST3, they can do low outlet forceps. Okay, so you go arrange your PPH till your consultant arrive, and send your ST2 over there with one of the senior midwives. This is the way to do it. And sometime if it's really go mad, then you can ask them, that you will get if there are 2-3 these type of urgent emergencies going on. One is prolonged bradycardia, 3 and she's still not fully dilated. One is major PPH going on. There is another one, maybe some serious similar type of really emergency, like preeclampsia going on. In that case, because all of these patients now require either the consultant or ST5, okay? And it's you and one consultant, so you can request the night consultant on the night ST5. You can say, if that is, then, and they are dealing with those patients already before you arrive anyway, and they're not going to just leave and disappear because no, you're here, our hands up, we are going. So sometimes they just need to be aware. So again, this is about the awareness. Don't go into the long details of the management. What happens, you start going into the detail of the management, and then you run out of the time. Okay. So at this stage, I can take a couple of questions. But whoever wants to ask a question, please speak, because there's so many messages, I won't be able to read all the messages. Any questions, anything particularly you want to ask? Okay, so that's the, are you guys able to hear me?
Can I please ask a question, ma'am?
Yeah, sure.
Yeah. So we are really in doubt if there is a primary breach and if she's, let's say, in active labor. Let's say she's 6 centimeters. So
Yeah.
should we treat them as an urgent or semi-urgent?
Okay, so that all depend what discussion has taken place. Okay, so again, your background information here you will need to ask will be from the, like, when she arrived. So if the patient is already 3-4 hours on the floor, then it's likely she has opted to go for vaginal birth. But you still can ask, if, say, for example, it was undiagnosed breach. Usually this is sort of scenario with the breach they give you, undiagnosed breach, 6 centimeters here for 2 hours or something. You just need to background information you need to ask. So has the mode of delivery discussed with the patient? but she has chosen. If she wants to go for a vaginal birth, then just a couple of more information pieces. Obviously, the previous team would have taken the decision to allow her go for vaginal breech birth. If obviously the rest of the, the attitude and the type of the breech, all that satisfied the criteria for vaginal birth. But still, for your point of view, you can also ask, like, so has the ultrasound been done and it's a favorable breech for vaginal birth?
Yeah.
So if she's
So
for vaginal
basically, we
birth, that's
will ask
fine.
the background to decide whether how we'll treat her.
No, it's not you. Right? So making the decision of mode of delivery is patient's right. She will take the decision. Yeah. So, but you need to ask, has this been discussed with the patient? So when you are asking your colleague, has this been discussed with the patient already? That means you are expecting that she has been actually told the advantages and disadvantages of the breech, vaginal, and the cesarean both. So if she has opted, if the answer from the examiner come to you, and then you can say, okay, can I have the partogram and CT? Is there any other risk factor? As I said, like quick question, have there been any other risk factor, maternal or fetal risk factor in this pregnancy or in the previous pregnancies? And if there isn't, that's fine. You will say, I will send one of my senior midwife. This patient, obviously, this breech needs to be delivered by, the experienced clinician. And vaginal breech usually are delivered by the consultants, because if they now again the vaginal breech delivery is becoming more common. Patients are opting it, and as the clinicians, we are feeling confident to offer women as well. But there are, like, usually at ST5 level, people may still not have enough experience. So if you go to the guideline, the safety point there says the vaginal breech should be delivered by the clinician with the previous experience of birth. So usually you can say up to the consultant. Okay, so you will say, I will ask the midwife to continue with the CTG and monitor the labor, and obviously then when she's fully dilated, inform us, so the consultant or one of you can attend for the delivery. The needs to be delivered by senior practitioner, okay, clinician. If then the examiner says no, she has just arrived actually half an hour, and the team was, and maybe scenario says already arrived half an hour ago or something, and obviously there were emergencies going on, then nobody actually has been able to go and see that breech woman. Then the way you will say is very important, that first of all needs to have a quick review of the notes to see if there has been any other risk factors, and then to have a discussion with the patient. So here you will start with, like, the first of all, ultrasound scan needs to be done before even we go into the discussion. Yeah, because if it's not favorable breech according to our ultrasound findings, there is no purpose of starting the discussion beforehand and then to the scanner say, well, hang on a minute, actually this is not favorable breech, we can deliver this way, we really should go for cesarean section, right? So just logical, be logical. Somebody has just came in, you want to, first of all, let's see if there is any risk factor. No, okay, that means we can actually consider both options. Okay, let's do the scan first and see, is it actually the type of the breech we can deliver and the other criteria meets to the vaginal birth? Then yes, we will have a discussion, and all you need to say is, we'll have a discussion with the women, and you can send your ST3 or ST4 as well to discuss the advantages and disadvantages of the vaginal breech, and also advantages and disadvantages of the cesarean section, and then she inform us what way she would like, how she would like to deliver. And that's fine, you can leave here now, unless examiner then herself say, okay, so the discussion has taken place and she now say that I want to go for the cesarean section. If that woman is wanting to go for cesarean section, then we can't delay her cesarean based on her cervical dilatation, unless she's not in active labor. Then we could buy a little bit more time. But if she is in active labor, 3, 4, 5 centimeters, 6 centimeters, then she needs to be delivered within 1 hour by cesarean section if she opts for cesarean section. Yeah. And then obviously that cesarean also needs to be done by ST5. Then you can say, but obviously you can start with your PPH first, and then your consultant will be there to maybe take over with the PPH, and she probably will have the night consultant with her as well to assist with her, and then you can do that cesarean after an hour, within an hour. Or if you have ST4, depending upon, she should be able to do the cesarean as well. So just keep it as simple. Yeah.
Yeah.
But you won't be basically giving the decision that, you know, all you need to do is just openly, these are the advantages, disadvantages of this, these are the advantages and disadvantages. Even though, even if we know clearly that this one option is better, the way we say to them is we will say, okay, first I will neutrally tell these are the advantages, disadvantages of both, and then we'll say, under your circumstances, because this is, we recommend, say for example, yeah, if it wasn't the breech position in right, whatever, or some any other case, you know, where I clearly feel that we should go for this one, the word I will use, I will say we recommend, you know, to have this treatment. But obviously it's your choice. What would you like us to do? Okay, right.
Thank
And
you,
we
ma'am.
discussed that like as a conflict of decision making in our last session. So you can just listen that as well. When if there is like what we feel is better for the patient, but the patient is going for something else, the other way, how we then actually inform them and then
Negotiation.
take the option.
Yeah.
So what happens when we have some unexpected situation arisen or in the emergencies again? Just simple pathways to follow that. So for example, just simple, this one I have done. This is more again, not about, so when there are some intraoperative injuries, these scenarios when they're given in the exam, say you have cause injury to the bladder maybe, or the ureter has been cut, or your lovely assistant has actually perforated the uterus with trocar, anything like that. These are not basically to judge your surgical skills. They're not like you tell me like, you know, this is how we're going to do the bladder repair and then follow up and all that stuff. No, this is, we call it as a situational awareness. Okay, so you might be aware of this new, not new here in UK, it's been really, there is a large emphasis on these human factors and situational awareness aspect of care for last few years, which means like the team should be aware of overall what is going on and then take the steps at right time. Okay, so usually when there is an injury or something like that, the way is very standard again. As a surgeon, it came from civil aviation, basically from the pilot's point of view. When they have the emergencies, don't just keep thinking in your mind, I'm going to do this and I should do this. No, speak, think loud, that I'm going to, so that your colleagues, because when we are under a lot of stress, sometimes we lose the awareness of time, how much time we have actually lost. There is some there is some bleeding, and we are trying to just suture and feel like I'm just going to get hold of this bleeding now. Just, yes, I'm just getting there. And it keep going on and on. And when you are doing it, you're so much focused to try to, you lose the awareness at the time, how much time actually has been gone already and how much blood loss has happened. So if you're not speaking aloud and involving your all the team, what is going on and what you're planning and what's going on. And the same way, the team also needs to see, even if you're not speaking, the team is aware, they can actually interrupt you and shake up. Dr. Jabin, is not coming under control. Let's call the consultant. Yeah, this way. So this is the training of the whole team. So in these scenarios, basically is in intraoperative or any major kind of emergencies, again, the one is you will say immediately say, I will, tell the team that I'm suspecting this injury. So I will ask them. So start from your, obviously, anesthetist is the most first person to tell, so he can manage for his anesthesia. So we'll let him know this has happened. So we may need a prolonged anesthesia. Now, obviously, the procedure is going to be prolonged. So that he can actually, you know, do manage his anesthesia accordingly. Then obviously you're going to ask somebody to call your consultant and inform them that, you know, you're suspecting this injury has happened, and whatever the reason is, say what was this injury to bladder, okay, and she's not catheterized. So here what you will say is, the other thing immediately you need to do is you will ask one of the colleagues or somebody to catheterize the patient. You're going to actually withhold now for the surgery, everything. All you will say I will secure the hemostasis, and then just wait for the consultant. And you're going to basically call your urologist as well, right? So sometimes people feel like they need to repair, they can repair. Yes, you get the training. We are aware how to do the bladder training, repair or whatever, but we don't do them on routine basis. Okay, so we are not as skilled as the urologists are. So again, the patient, we are committed to give patient the best quality of the care. So it will be urologist who will come and repair it. So you need to say, you know, you will call the urologist as well to and inform them you need assistance there. It's okay, even the urologist and the consultant come and they check whatever, and then they say, no, there is no injury. That's okay. This is fine and more acceptable rather than you thinking, I think there is injury, maybe not. Yeah, I check and not. And if you have checked, no, I'm not sure, and then you close the person, and the next day they have all that sepsis and everything in there. Okay, so nobody mind here for you to be. So this is about again checking you are a safe surgeon, and you know you don't hesitate to call for help when you require it. You know your limitations. Yeah, you would have heard all these words. So yes, you will say like I will ask them to call the consultant and also the urologist that during the surgery I'm suspecting there has been bladder injury, and if she's not catheterized, you will ask one of your colleagues to catheterize the patient. I will secure the hemostasis and just withhold and wait for the consultant and the urologist to arrive. You're going to obviously tell your scrub nurse as well that I'm suspecting this injury, so she can have the other trolley or the instruments ready for the bladder repair if required. Yeah. So that you will do, and then you will say once the consultant arrive, you will hand over the obviously the surgery to the consultant, and then unless now at this stage examiner then ask you, okay, tell me how we diagnose the an injury to the ureter or the bladder. Yes, that's fine. Then say this is what we do. Or if they say, okay, how we repair the bladder, then just go for bladder repair. If they're not asking, all this is fine for you just to say that they will be done by the urologist. No, the other important then the way continue is, and the main marks are for you to actually speak and call the right people in, call the nurse, the scrub nurse, get the patient catheterized. And then obviously you will say, okay, so once the surgery is completed, whatever is done, then the patient will be transferred to obviously high dependency unit for close monitoring. You can now continue that side by saying, so when the patient wake up, you will see, go and personally see the woman and explain, and also inform that happened because of the error was made that we, for some reason did not pass the catheter. And then you will also say, continue to do that I will reassure the women that we will actually report this as an incidence, and we will do the detailed analysis of the incidents to see why we failed, right? So here is, we have here clearly made an error. Okay, so I'm going to say why we failed. And we couldn't find it, and then we will learn the lesson and share their learning as well to ensure that this does not happen again. So this is what the patients, most of the patients want to hear when they have some complaint or they're very angry. They are okay to accept what wrong you have done with them, as long as you accept it, apologize, and you say, we are going to actually learn from this and we are going to make sure it doesn't happen in future, the same way. So this you will do, and then you will say, okay, and then obviously you're going to follow up and liaise with the urologist as well later on for the bladder care and stuff. And then before the discharge, again, important thing, before the discharge, I will go and see the woman again to make sure if she has any questions or concerns she want to ask, I answer them, explain her again if there is anything she's not clear about, arrange her appropriate follow-up in our clinic as well as for the urology clinic. Okay, so this is how you will actually complete your care or responsibility towards that patient. Then now you can think about your team and everything. So then you will say, okay, so at the end of this procedure, we are going to have a team debrief as well. And that team debrief will be then also to say what went wrong. Yeah, we have obviously the again for these situational awareness and stuff, we do have that checklist we should have done, and that checklist should have done the patient is catheterized, yes, catheterized. So we need to then use the team brief, we will then find what went wrong, why we missed to catheterize this patient. So because that will help you, maybe that was the assistant who was supposed to catheterize, maybe she was a new person, she didn't know this patient needs catheterization, or she actually was supposed to go somewhere else, she was for OPD, and the sister you were going to have your ST1 or ST2, she fell ill today, call off sick. So this other girl is being called just from OPD to come and assist you. So she just has really rushed, washed up, and the nurses are telling you, you need to be quick. just, blah, blah, blah. And she didn't realize what has already been done and not done. Okay, so it's very important for us to find out what, so that we can then correct in future why, if that situation happens, what we need to make sure. And then again, so the person, whoever was responsible, according to whatever that we have to catheterize the patient, that person and colleague is also going to go under immense pressure now. She made the mistake, and that's why this patient has gone through. So then we need to also say, it is very important then to think about the support to that colleague. It's not only blaming and find out why you did this and why went wrong. It's also to support her for the time being. Okay, and tell her like, so move her to the side room, give her a drink, and afterwards speak to her, check with her how nervous she is. If she's quite upset and nervous because of this error, then check, make sure is she okay and safe enough to continue with the rest of the shift and the work or not, and if not, then speak to the concerned and send her home. Very important. Okay, and then you'll say, you will take your responsibility as well as a surgeon. Yeah, it's my job as well to just to make sure before I put the knife to the skin, to make sure, okay, kind of just think, okay, and at least speak to my assistant first time to say, you have done, so is she catheterized, is she done, and just assess her if she's a new one. Have you done this procedure before? And so I have failed here as well. Yeah, so it's important to acknowledge that as well, that I have failed as well, to assess that. The same template you can apply to that trocar injury as well. Okay. And then you say, okay, so you need to do a reflection on this as well. You will ask your junior colleague to do the reflection on this as well, what we did and how we could have done it better, what we have learned and how we're going to apply in our future practice. And then you will say, okay, so then I will arrange a meeting with my this junior colleague after 2 or 3 days, where we both can actually reflect and see what went wrong and how this can be. And then you will say, I will write the reflection note on this and discuss with my supervisor now and later on during my appraisal meeting as well. And you will encourage your junior to do the same, to actually discuss with her supervisor at this stage as well, and then reflect in there as well. So this is how that comes in. And you can see how important it is. So the major, almost all the marks basically are on your non-surgical skills. They are on your situational awareness skills. They are on your human factor skills. Okay, so you need to judge what are they wanting. So yeah, so we said like sometime we need to communicate with our colleagues under the circumstances where we feel they are not well, so their well-being, which I give a little example about physical well-being. Sometimes it's mental well-being, and most of the time it's mental well-being, because people are pretty good to recognize when they are physically unwell, to discuss it with others, and also to take time off from work. We all, in spite of all these awareness, still most of us are very poor actually to assess our mental well-being, and then confident enough basically to decide, at some stage when we had enough, no, we need help, we must do something about it. And if we're not safe to practice, we must take some time off. Okay, so for that reason, this is strongly encouraged now, and is a part of the training, that you must be aware if that particularly herself or himself is not recognizing that, then as a team, you must be aware of your colleagues, all these steps as well. And then it might just be to just go to that colleague and say, well, are you okay? I have just, I was a bit concerned by seeing that you seem to be a bit detached and not, a bit stressful to me. I may be wrong, but I just thought I just check on you that you're okay. If they open up, that's fine. If they don't, oh, no, it's all right. No, nothing much going on. And most of the time it happens, they don't open up first time anyway. Then we usually say, okay, no, that's fine. That's good to know that you're fine. But just in case, at any stage, if you feel you would like to speak to somebody, um, you know, I'm open. I will be really happy to talk to you about that, and help if I can in any way. Okay, and we do that quite, it's not uncommon. And sometimes there's nothing. All that might come is like saying, oh my, maybe, mom or maybe sister or brother or somebody's unwell, and I'm really worried about, and or my mom was not well, and I have to go now and do shopping for her as well, her grocery, her stuff. So I'm really not getting enough time to sleep, and I'm really tired. Sometime it may be as simple as this, and then it's just like just giving that person a little bit of encouragement. They're saying, okay, so do you think you have some sports? So what other sport you have? So try to give her an ideas what else she could do, basically. Maybe if there are other sister brothers as well, to ask them as well, or get some help, or maybe speak to your mom's GP and arrange for carer. Or maybe do you want to consider to take some time off and make these arrangements? Did you sort out these arrangements for your mom, and then you can come back to work? Yeah, these type of things. So again, very natural and simple things you do all the time. So so this bullying, harassment, and undermining happens, unfortunately, still happen, and quite commonly happens. And most of the time, the people who are bullying, they are not aware they are bullying, actually. And the victims who are getting bullied, they are just taking it and they think, okay, there's nothing really they can do. So it's not really uncommon to still to see that, in spite of all these trainings, all these awareness, and because these processes can be quite stressful. So there is a standard protocol for that one, how we deal them as well, because they are quite sensitive issues as well. The protocol, according to every trust, have their own bullying and harassment policy. It's must for them. It's legal requirement. They must have a policy. And policy mean, again, a pathway where they give that information to their employees to tell them these policies are usually to them. This trust has a zero tolerance to bullying and harassment. And then they tell you the steps, what you can do. Or if you notice any of your colleague is being bullied, or you yourself are bullied, then they basically give you the instruction. These are the people you can contact and speak. And this is what we do. They also tell them, if you will speak to us what we do, then there is informal way, and then there's a formal procedure. Usually the first one is informal, where basically is like speak to your supervisor or even to human resources, and they will speak to the other person or send them a statement to say, well, we have just somebody has raised concern or said this about you, what you have to say about it. And they might arrange a meeting just to basically make that person aware. And if that person just recognize and say, oh, I'm really sorry, I felt so awful that that because I made somebody so much upset. Now I never thought of, I didn't mean to, and that's all is required. And after that, that person might become mindful now that she needs to change the way she speak, maybe, or approach other people, or what she does. Yeah, and that's all which was required to done. But if not, if that person is still not sorted, then obviously there can be next can be the formal procedure. And formal procedure obviously then have obviously that goes in a written, and there are meetings. Then both sides will give their statements, and then obviously there will be a team actually defined who will be doing that inquiry. And then they will see, okay, either if they find no, actually not, it's not, they might give a little bit of, it's a mild thing, they might give some guidance and instruction to the bully, that you do this, you need to improve this. And sometimes they arrange some training courses for them to go on. In the same way, the victim, they speak to them as well. They will tell them, okay, this is how you should are, and then also arrange some maybe training courses for that person as well, to say how to manage, how to communicate with difficult colleagues. Sometimes some people are just like that by their personality characteristics. That's the way they speak. And they can't change it. Then the other side, we also have the training part as well, how to deal with your difficult colleagues. So as long as you know the personality types, that sometimes give us, yeah, this person actually spoke quite loud in this way, but basically this person speak that way to everybody. But now after, speaking and everything, it's not like right from the start, it shouldn't be an approach to think, well, she probably speak like that, so I need to take. Even if she speaks to everybody like that, and when she speaks to me and that's upsetting me and causing me, I'm disturbed and I'm not comfortable, that is bullying. Okay, so that needs to be done. Something needs to be done about it. Okay, so usually the way, now coming to the detail, is like, first of all, what are the steps? First of all is obviously you will go speak to your colleague first, just the way I have told. Ask that person, okay, I see you look quite upset. Are you okay? Is there anything which is bothering you? Would you like to discuss with me? Are you sure it all will be absolutely confidential. I will not share with anybody unless obviously, you're happy for me to do so. So first give that reassurance, then ask. So the way is when in the exam and even in real scenario when that happens, you sit quiet and passive. Let that person completely describe what that person feels about it. So don't start with the leading question straight away. Just ask, tell me what is happening, what is bothering you. And that person will start telling you, okay, this particular midwife, this colleague, blah, 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 whoever is doing this. And then just ask them. Sometimes they just say they are always, rude with me, blah, blah. Then we ask them to say, oh, I'm very sorry. And it's again natural response, isn't it? We feel sorry for that person to go through. I'm sorry that you've been going through this awful, and you've been really upset. And then I will ask her to say, okay, so can you give me any specific example, like describe some specific example for some time when you feel they happened. Because sometimes if we are just simply saying, well, that person always speak to me like this, that person always like do that to me, maybe this person's interpretation is not right. So we need to be specific. That person needs to be specific. And then we usually encourage them to say, tell me some specific event, what happened. And then they will tell you, okay, this happened. And then you say, no, yeah, that's right. That is absolutely unacceptable. And this should not happen. Okay. And then again, ask that person, because it's not you. See that person, you may help her to tell, do this, or speak to the supervisor today. She's very upset. Your trainee is being bullied with their other colleague. Do something about it. But that person needs to learn the skill as well, how actually she should encounter these bully and what she should do, because she has to live with it. Maybe some people are vulnerable by personality wise. So they need to also learn how they need to, how they can actually, stop people bullying them. So next step I'm going to ask this girl is, I will ask like, so have you done anything about it? What have you done till so far? So answer may be, well, I haven't done anything. Well, I'm just new here, and she's such a senior member of the team, and that usually is, the fact this way. And then you say, okay, no, yes, I understand that is, but being senior does not mean she should bully anybody. Nobody should be bullied at all, and there is a zero tolerance on that. Okay, and then you ask how you feel about speaking to your supervisor. So first of all, encourage them either how you feel about talking to that person and telling them that their behavior is causing me that upset, because they might not actually be aware that their behavior is causing upset. So this usually the people who are bullied, obviously they don't take that option, and that's natural. If I'm worried and I'm scared of somebody and I'm really bullied and all that upset, that's the hardest thing to do, to go to that person and clearly speak to them and say, your behavior is causing me upset, because we start becoming scared of that person. So, but that is the best way to start with. Okay, because sometimes it just can just get resolved at lower level. And then if not, if that person say, oh, no way, I can't just speak to that person, then the next step is to encourage that person to go and speak to their supervisor, whoever their supervisor is. Even if it's a consultant, obviously they can speak to some other colleague, or they can speak directly to human resources. So you will encourage that person to speak to and then ask how you feel about that. Yeah. I can, if you want, if the person says, no, I don't know if I can do that, or blah blah, so how will it be helpful if I come with you, or if I speak to just to let your consultant know that you're upset, so he or she can speak to you then. Yeah, offer the next step. And then you can say, the next one is, you can say, okay, you can speak. And sometimes you might feel that particular consultant and the other person is very close friends or blah, blah, favorite nurse of that consultant. She may not be actually comfortable, okay? Then give her the options. Tell her who else she can speak. You can speak to clinical tutor. You can directly speak to human resources, and there is a nominated person according to the trust policy for this issue, right? So we can tell, I can look for that, who is actually the the lead for this anti-bullying and harassment. You can write or give them a ring and speak to that person themselves. Then the other very important, some people just do not feel the courage basically to present their issue or their problem themselves. So we have British Medical Association here called BMA, and almost every practitioner here is member of that association. They provide support in all these matters. So and they advise, they also tell you what to do, and sometimes they even present for you, not sometimes, almost all the time. So then you will encourage that person to say, okay, so are you a member of BMA or British Medical Association? If not, even you can give them a ring, and they provide a lot of support to the doctors on this matter. Okay, they will actually help you what can be done about this, and they can even write a statement and speak to your consultant or to them on your behalf. And then obviously that actually works because they are recognized body. When they raise the issue, that's taken seriously, and the things are done in a serious way then. And if not, again, this is informal procedure. Okay, so first of all, that will happen, and if that doesn't work, then obviously the next one is formal procedure, where a proper inquiry will take place, and the person who is bullying can be penalized as well. So that's that bit, to tell her about the process, what you can do. Then the very main important aspect, the other one, is to make sure that how is she dealing with that? When that is happening, or we are stressed for any reason, what happens? We do have all physical signs of this stress and everything. I have headaches, eating and drinking, our self-esteem go down. We go home and we are so irritated and stressed out already. We just, diverge that all our family and kids, we shouting on them. And so you need to establish then, like, how you are coping with this. Obviously, this can make you even physically ill. Are you having any symptoms, headaches? Just check. Are you eating, drinking well? Is there any sport at home? Have you spoken to anybody at home? If you haven't spoken here at work, have you spoken with your partner or anybody? What sport you have? Are you able to eat and drink properly? And you sleeping properly? Do you find difficult to come to work? Or you feel you're struggling to concentrate? And it's affecting your concentration and quality of work. And if that is the case, then you will say, well, I will really encourage you to speak to your GP and get some help from your, and take maybe a week or so off from work to give yourself rest. Think about how you should proceed for this, and also help you to recover from this, just to come back a little bit more fresh and deal that with. Because it's important, if you're so tired and you're so not able to focus and concentrate, which it can affect this type of behavior. Let's not say if you are vulnerable to make a lot of errors and mistakes, which obviously not right, neither for yourself and not for the patient's safety. Yeah, so we're going to encourage her to take some time off. Then you offer her counseling as well, by saying very simple thing to say her, and then say there is a lot of counseling help available as well. So there are three main channels she can go on. Number one, she can arrange some counseling through the GP. If she doesn't want to, we do have our occupational health. They have the counseling, and that's like confidential. Like, even if we take it from work, from occupational health, nobody's going to, and it doesn't even go into our main medical records if you don't want to. So that one. And then BMA itself provide doctor to doctor counseling as well. So mostly we encourage doctors actually to take that counseling from the BMA, because then the other side, they are also the doctors and their colleagues, and they're very well aware of these type of things and circumstances, so they can also guide. So these are the three channels you can guide that girl to. And that's what it is. If she's not right prepared at this stage, and she says, well, I'm not sure what I want to do, then you can say, okay, that's fine, that's okay, you don't have to rush. Okay, I can understand it can be quite stressful to do this all as well. So take some time, but meanwhile, please look after your physical health. Take some time off then to think about, once you are well hydrated, you have good sleep and all that, you will be able to think in a better and more logical way. Right then. Any quick questions?
Ma'am,
Yeah.
hello.
Yeah.
Yeah, ma'am, you
Yes.
mentioned in the station that something, are you member of some British or something like that? I didn't get it actually. Can you
British
repeat that?
British Medical, that's British Medical Association. It's also called BMA. That's a, you can
Okay.
say, a union or the sporting body for doctors. Okay.
Okay.
Ma'am, one
So
doubt.
So in the station of the bullying, how we are going to mention this regarding like what is the importance of this?
importance of what? BMA?
So you have asked the person who is suffering from, who is get undermined, that are you a member of British Medical Association, and they are going to write it. Like if the person is scared to raise the complaint, then how to go about the station?
No, no, not about the, if they are, then for the time being, if they say you have given those, those options which I have discussed, like, go speak to the person who's causing you upset, or speak to your supervisor, clinical tutor, and all that, then you're giving her different options that you can do it through BMA. And basically, even we go and other than like the first time we maybe speak to the consultant in an informal way to say this person's particular behavior is causing me upset. Anything more than that, if you want to do, we always go through BMA, because that's your union, that's your sporting body. They support you not only to present your cases, they also back up in future. Say, for example, for the time being, I have reported this bully, and some things have happened to make her to fix her behavior, but she may not be one of those people we take it as a constructive, and she might just keep that in that revenge type of thing in her mind, and she might behave like a couple of months or 6 months, and after that she actually come back even with more revenge. So who is going to now save me from, and it can be sometime even your own consultant. So who is going to then? And these are like these people, they, because it's like according to law, it doesn't matter whether it's your consultant or how hierarchy that person is who is bullying you, is zero tolerance. They can't, so they provide us protection from that as well. So I mean, we do pay their membership fee for that purpose. Okay.
Ma'am,
And if,
one doubt,
yeah,
ma'am.
so yeah.
Ma'am, being bullied by the midwife and being bullied by the senior consultant, do both of these go by the same pathway? Or do you have any?
Exactly. Yes. That's why I said it doesn't matter the person who's bullying is colleague from other specialty, from some other discipline, or is your own consultant, or even if it could be your whatever clinical tutor. It does not matter. Nobody has the right to bully, even their junior most colleague. Okay, there are strict policies, there are strict steps in, and that's why it's part of your exam as well that you need to be aware. So don't be scared to if you are bullied yourself to take these steps, or if you watch some colleague is being bullied, to encourage them to take these steps. Okay.
Thank you.
Hi, Dr.
So
Safia.
yeah.
Nice to hear you after a long time.
Thank you.
Dr. Safia, what I understand that you explained that first of all to speak with the supervisor who will be consultant, any
Yeah.
consultant that for her, and next
Yeah.
will be that human resource. If she doesn't like human resource, also she can go, and
Yeah.
then clinical tutors. Clinical
I
tutors.
mean, just think about like when there is you try to start things in a simple way. Yeah. So the
Mm,
closest person to you is in your team your supervisor, because you are
yeah.
spending most of the time, and he's actually responsible for your training and also for all these aspects, right? So it's just
Yeah.
natural to go and speak to the supervisor. The next is then you have your clinical tutor within the team in your department, right? So it's more natural and more comfortable to approach that person before I go to human resources or somebody else, unless I have a complaint straight away against the clinical tutor or the supervisor. Then yes, I will go maybe outside the department and see who is the next person according to our trust policy, who should I contact. Then yes, you could go there, but before that obviously you will speak to, so it's not like stepwise. Nobody has necessarily always need to start from supervisor and the clinical tutor. It's just a natural pathway we suggest them. She can start straight away, give them a ring, give a ring, and usually that happens, to be honest. Everybody basically, because we know we are members, and that's what we are paying the fee to British Medical Association, we basically give them a ring first. We always speak to them first. So they kind of tell us these things, and if we say no, I can't, or I feel that actually my own consultant is bullying me, how can I, then they will say okay, that's fine doctor, we can, they will take all the details and they will write a statement for on your behalf, and they will send to their respective department.
And clinical director, who will be the clinical director? Is it the consultant?
Okay.
Any consultant?
Right. So yes, the clinical director is some consultant, but that consultant may not be straight from clinical director is different. Okay. Let me just tell you about the staff formation. So you have your specialty team, say of obs and gynae. So you have different consultants in them. Some is labor ward consultant, urogynae consultant, fetal-maternal medicine consultant. There are teams. Then you have two consultants with one with the administrative responsibilities. They are called clinical lead. Okay, they're called clinical lead. So it's a consultant of the same specialty, but this person will be overall looking and will be responsible to make sure the workforce rotas, if some doctors are less and not, who to cover, recruit, and all that stuff. Then you got clinical tutor. That's again some consultant. It may be your labor ward consultant, it may be your urogynae consultant. So that person is clinical tutor. That person additional responsibility or role of that consultant is basically to coordinate with the college and the deanery about the training of the these STs, and to make sure their curriculum and they are getting the training and all those arrange their appraisals and everything. So these are within your department. Clinical director basically is, again, then it goes a bit more. So there is a group of specialties. So gynae obstetric itself is a large specialty. We may have clinical director within just for the obs and gynae, but usually it can be the clinical director covers 2-3 different specialties. So say for example, it may be gynae obstetric and peds together. For both these departments, there may be one consultant from any of these departments which will work as a clinical director. Okay, so just a bit more higher level where we have like combined meetings, clinical governors, and they can overall look after, to see all the consultants matters as well, the recruitments and all that stuff. So the clinical director doesn't necessarily need to be within your own team or your specialty. Okay. Say for example, in medicine, in some of the allied medical ones, say for example, we can say rheumatology, dermatology, ophthalmology, sexual health, GUM, all these smaller specialty together will make one domain, and they may have a clinical director as well, and that clinical director may be a consultant of rheumatology. Or somebody, right? So within your team is clinical lead and the clinical tutor. But then you have your own named supervisor for every trainee as well, who you are working with as a team. When that consultant has a theater list, you are supposed to basically be in that theater list with that consultant. When that consultant has a clinic, you will be going in the clinic with that consultant. You will be doing your morning round with that consultant. That is your clinical supervisor. Okay. So all training related and all these type of issues, anything, because he's the person basically as a family you are working with all the time. Yeah, so that's very natural. And that person could be your clinical tutor. Your clinical tutor can be your supervisor as well. That you just are, working with me. I'm clinical tutor as well. And then I'm seeing my patients and doing that stuff as well. So it may be the same person. Just for to help you to understand. But yeah.
So any summative process or if I'll do any procedure, so at that time also need two consultants to be signed, isn't it?
What? Sorry, what?
Any summative process that if I'll do any procedure, so my consultant will be. So
we will go to that.
Consultant.
So let's not go into that, Salma, at this stage. We will go to that, and
Right.
I have teaching at the end.
Okay,
so
thank you very much.
Yeah,
thank you.
You're welcome. You're welcome. Okay, so continuing with the, so sometimes they put it as a structured discussion, this bullying and harassment. So they give you that type of procedure, station outside, and then they have the discussion, the consultant for you to ask the question. So examiner, what will be your immediate response to that? And we discuss that. Yeah, so listen that recording again, that you're going to approach, how will you take it forward, means like how you need to basically are going to tell her, this one will be to understand from her, and then make sure that how much physically and mentally she's upset, is she safe to continue with the work. Second one, how will you take it forward? That will involve that to say, that you will encourage that person to find out, has she done anything? You will encourage her to do something about it, because it must stop. It's going to affect you. It might be some other colleagues might be getting bullied as well. So how does your trust deal with such a situation? The trust has a trust policy. every trust has a the trust policy on anti-bullying and harassment, so we will accordingly, and then you can speak all those steps I have told. What will you do if you find midwives that are undermining your colleagues? Same thing. I don't know why they have put it separately again. What are the consequences of undermining? Yeah, so we did discuss the consequences. That person's training is going to affect it. He will have a low esteem. He's going to cause physical damage to health and all that. He will become he will be making errors. He won't be safe to continue. These are the consequences, and that's why we encourage people to stop taking it. How can you prevent bullying at your workplace? So simple, give that awareness. Whenever we do have obviously regular, it's mandatory for us to read some of these important policies. They are sent to us, and then we have to read and mark on that being read, so that we are aware of that policy. We can do some educational, we can make the awareness training on anti-bullying and harassment. There are courses we go for as well, how they should be dealt with. So this is how you will prevent it, and encourage people not to take the bullying, and also, not themselves, and also keep an eye on their colleagues as well. And if they see somebody is being bullied, we must come forward and speak to that person and encourage that person to take steps around them or help them and facilitate them. So that comes to the end of communication bits. Then the third main domain is safety and quality improvement. Now, safety and quality improvement, what that is, safety and quality improvement is about, everything. About how much care from patient's point of view, from the training and the capabilities of the clinicians as well, that we need to make sure they are safe, and they are providing quality care. So including all that, the clinician should be up to date with their clinical knowledge, and they should be doing their appraisals and their assessment, that everything, including clinical risk management and everything. So safety and quality improvement, there are two main things here. Like, one is clinical governance when it's applied. Yeah, so clinical governance obviously is like how we ensure that we are actually, as a team or as a trust or as a specialty, providing high quality care and safe care. And for this, obviously, we do have the different tools. We do clinical audits on practices to see, are we meeting with the national standards which has been described, are we not? And if we feel we are not doing that, then obviously we do make those changes and try to improve. Risk management, in the previous couple of cases, we just talk about where that injury or something happened, we said we will complete and report it as a incidence. Again, that one not for the blaming or for penalizing, that one is just to try to understand what went wrong, or what we missed, what we could have done differently, and then we do detailed analysis first to find out the factors in that one, and then to learn as well, and then also to then recommend what we should do in future so that it doesn't happen. Yeah, so obviously that is ultimately going to improve the quality and the care and the quality standard for the patients. Maternity dashboard monitoring is also part of. So you are aware of maternity dashboards. Maternity dashboards are like some very quick, we can say, live monitoring of our performance of different. So we do have our clinical standards, and then we have our green range and amber range and red range. If we go certain number of cases of complaints, maybe cesarean section rate going high from that, that just give us looking just on that dashboard. If we are performing within the standards defined by the national standards, then our numbers stay in the green. And if we are performing, so say it should be 25%, if ours were 26, it automatically will become red, and that will alert me from the color and everything that I should just do, again, situational awareness. That will alert me of being red. I need to look into carefully and see what happened in this month, why. Again, yeah, so for that one, we might go to clinical audit or just do see individually what we can improve. And learning from reflective practices, as I discussed in the previous case as well, they all come under, examples of safety and quality improvement. Then we have safeguarding pathways as well. Like just like as one we have done, that actually is also safeguarding for of colleagues from bullying on all these behaviors. Then overall safeguarding, adult safeguarding, and child safeguarding, they are very well defined national pathways, and we just should follow them straight away. I have another one other recording and presentation on safeguarding in my one of recordings on the YouTube. I will show you the link at the end. I'm not going to go into the detail of that pathway. You all can watch that video and that will tell you in detail what and how we follow them. But again, they are very standard robotic and you are supposed to know them in a robotic manner as well. This is the step, this is the step, this is steps. Again, they are made standardized and they are national standards. So everybody's following those steps. So you don't miss anything. And overall situational awareness, just like as I said, like when we are doing PPH and major events or even theater and stuff, like sometimes we are just very busy doing what we think are doing and we lose the awareness of the time, we lose the awareness, we could do this different. That is very important, situational awareness basically. So say for an example of safeguarding pathway, this type of scenario is appearing in the exam as a role player, as a structured discussion as well, where a 9-year-old girl is sent by GP with some verbal sores and the GP feels it's genital herpes and she's attending A&E with the mother. Yes, it has two parts. Obviously, one is maybe 1/4 marks is about your knowledge of maybe that you need to take some swab for HSV and start treatment for that girl and give her some pain relief and stuff. But the major chunk, 75% of marks are you to be aware of the pathway, what we should be doing on that national pathway again. So what are you going to do? Immediate concern. So again, just forget what people are telling you or what it should be. Just try to think it naturally. You see a small girl, 9 years old girl coming to an and you are called to see that girl and she has a genital herpes. Obviously, there are two things immediately going to come into my shock. Oh, gosh, 9 years old, genital herpes, sexually transmitted infection. This girl is getting sexually abused. How much really, just think again, you are naturally going to be worried and concerned about this girl. Yeah. So that's what we want to think. I will be really concerned and I'm really worried about that this child is being sexually abused. Right. So this is what my immediate worry and concern or the reaction. The second one is obviously she's in a lot of pain and she's not able to pass urine. So her well-being, giving her comfort from that immediate pain, obviously that will be the first one for importance for me to sort out, to give her some local anesthetic, apply on those sores to make it comfortable, and then, encourage her to empty the bladder. And if she still can't, then just empty it with a catheter and then, talk about, and then it becomes the most important stuff then. Okay, so if she's sexually abused, then what are we going to do about it? Okay. So simply, obviously, you will go, and this 9-year-old girl, the children of this age, and particularly if they're abused, they usually are quite scared, frightened children, even adults who are victims of, domestic abuse and stuff. Those victims become very scared. They're not as confident, and they don't actually open up to the strangers straight away. So very simple. If it as a role player, you will go, obviously, you're going to first build up your rapport with this little child. So you will speak to the child, you're going to kneel down or sit on the floor to come to the level of the girl and gently speak to her, ask her what your name is and what you're doing and which school she goes and how is the school and what brings her in. Tell me about your pain, when it started, slowly and gradually in little things to rapport. And when she start opening up, then you can say, okay, so I'm sorry that you're having so much pain down there. So if it's okay with you, let me have a quick look down there to see what actually is, causing you so much pain. I may be able to apply some numbing cream at the same time as well. That will make you numb and that will take your pain away. So give her reassurance first, take her confidence, and then say, and then what we will do, all this pain, yes, this is pain because the sore as well, and because you're not able to pass urine, that's also causing you pain. So once we have done that, then you will be able to pass urine without pain. And if you couldn't, don't worry, then I will, will help you to empty your bladder. We might pass a little tube inside your, water bag and empty it. So this conversation, if it's a role play, you need to take with the child. And even if it's structured discussion, you need to say that. That's very important aspect. This girl is not going to let you touch otherwise, yeah? So it's important to tell what you're exactly going to do. So first that is sorted out, and then you will say that, after doing the rapport with the child, then obviously you're going to speak to the mother as well to say, to ask, okay, that you can take the child in your lap, or your mom can be there as well. And I'm going to take this. So once you have taken this form and you have done that, sorted out her pain relief and stuff, Calpol and stuff, then you are going to speak to the mom and say, first, obviously, you're going to encourage the child to tell what happened. Did you fall down? It could be injury, it could be anything. Although if the scenario is saying he faces painful ulcer suggestive of herpes, you're going to take that diagnosis as herpes simplex. Okay. And then you will say, okay, so then I'm going to speak to the mother. So you need to be very open here now. Okay, so you will say that discussion needs to be very open, because I'm very much, and I have serious concerns about the safety of this child, that this child is actually subjected to sexual abuse. I'm going to speak to the mother and say, well, I have these serious concerns about this child, and I will encourage her actually to share the information and cooperate with us uh, for the safety of the child. Um, and give the information, because no, being a mother, obviously it's very difficult. No mom can actually take this, there are little girl is being abused, whether it's by the partner or somebody else. If some mother is not opening up and reluctant, that's not that she necessarily would take straight away and we become judgmental, thinking she probably is a part of that as well. No, she might be harassed herself as well, that if she discuss with somebody, then what's going to happen to her and the children, right? So we actually need to be quite empathetic with our woman as well, to say, encourage first. And if she said, and someday she may not just be aware, actually she may not be, and she might say, no, I don't know. No, then you clearly need to say, because of this, I am worried that this child is being sexually abused. So do you have any concerns, about the safety or about any person where this child, spend the time? Then you take a bit more information from the mother, what she does, who she's living with, the partner or whoever is at the home is the biological father of the child or not, what are mothers in, who is taking and dropping child from the school, or where the child spend the time after school. Does the mother has any concerns about where the child goes to, any friend's house or any other relative's house? And what she's having, has she been worried about the child's altered behavior at all? Has she been told from the school anything about the child, that she's not, behaving the way she was, she's have become a bit quieter or something like that? So you take that information from the mother, and then you are going to very clearly tell to the mother that, because of these concerns, I'm not going to send this child home. I'm going to keep this here for two reasons. The one is, obviously we need to observe her for some time anyway, to make sure that she's able to pass urine afterwards as well. And more importantly, because I know need to speak to my consultant about my concerns as well, and about this safety issue, and also to the safeguarding team of our trust. Okay, so every trust again have a safeguarding team. We have safeguarding adult safeguarding team and children safeguarding team. So there is a lead, they are named people, and that we can just get that information from our intranet. So you will give a ring to your consultant first and tell them you got this girl, blah blah blah, and you are admitting this child. And then you're going to, obviously your consultant is also going to say yes, speak to safeguarding team as well. Then you're going to ring to them and then inform them this child has come with this blah blah blah. And then obviously they are going to take things from there. They will give you advice. Okay, no, anybody, any child under the age of 13, if has been like involved in any sexual activity, whether by grooming and exploitation, maybe not bullied always, that is rape, and that's reportable to police immediately. So in this case, we are basically immediately going to inform the police as well. Okay. So you are going to inform the police, but it's fine to speak to the safeguarding team first and take them on the board as well. And then you're going to tell the mother as well, I'm going to call the police. We need to know, mother may be very much worried about this, but you can say, don't worry about that. We are aware of these sensitive issues that can compromise your safety. And if there are other kids, so obviously you're going to ask beforehand, do you have any other children at home as well? So sometime we actually need to tell the police or the way that those children should be removed from there first, and then they arrest that victim and investigate or do whatever. So these will be the immediate things which needs to be done. Obviously, she has the source. No, the other important thing now, the after immediate, next needs to be done is obviously now to sort her the girls from sexual screening point of view. The children under age of 12 are not examined by the gynecologist. They are examined either by the pediatric consultant, not by the trainees. are by the adolescent gynae consultants. Okay, they will examine them. So you are just going to have a look on this, on those ulcers and take HSV swab. For the rest of the, obviously, other than that, we're not going to do anything at this stage anyway. We will wait for the healing, and then she will have the swabs for chlamydia and gonorrhea. And by that time, slowly, we will get an information about the child and do some counseling. Obviously, that must be very traumatic experience for the child as well. And then after the information, try to, we will take swabs, obviously, if there is a vaginal penetration, oral or anal as well. There will be appropriate swabs will be taken for chlamydia, gonorrhea, and obviously blood test for HIV, syphilis, and hepatitis. Although she's 9 years old, but you will, try to speak and explain that child why we need to do these examinations and these ones, and then obviously you need to inform the mother as well. We need to have a good counseling support here for mother and the child both. Okay, so these will be from the clinical point of view. Child, if we are admitting them, this child, we will try to keep this child in the side room rather than being in the ward, because the nature of the issue she has, we may need to, somebody else need to come and examine the source, and how that discussions which will take place. Yeah, the pediatric consultant will come, and the pediatric consultant will also speak and get information from the mother of the child. And if they are just in the ward in a bay next to the curtain, everybody will be listening. So just simple, because some girls told me the examiner asked, where will you keep this child? Yeah, side room, just simple. For this reason, a bit of privacy and the nature of the, all that's the confidentiality as well. Now, what is the pathway? So for exam point of view, that's all you need to do at this stage, that you will speak and you do this. What is the further, after these immediate one, what is the further pathway? The further pathway is then after all these stuff, what we do, then we have involved the police anyway here. They will look after the other aspects. Then we are going to, we make a referral to our safeguarding agencies, and they are called MARAC, MARAC, and they're multi-agency risk assessment conference. So these again are named teams in every region. And they have usually every town level, city level in one council level. And they do meet, this team have the representatives, some of police, again, named officers from the police, and then from education, from health, from social services. So they all together meet once or twice in a week, depending upon the area. And when we send these referrals, say we will send this, for this, and there is a standard referral form as well. We just simply tick to that. And if that meets the criteria, then we send that to them. They will review over there. And then now, instead of us individually trying to contact the school nurse and speak to her, what is going on, I mean, we're going to alert the school nurse here anyway to invite her in that meeting, and then contact social services. Then what? When this goes in there and all those people are sitting on the table, they might actually already have some information about them. They might have some information already, mother being the victim of domestic abuse, or some other child through some other child, or maybe school might have raised some concerns. So there may be some information already sitting with them. And if not, they can all just discuss and put a full plan in place. The police will say, okay, they are going to investigate all that case. They're going to arrest that person and find out, because that person might be actually bullying some other children in community as well. So there might actually be some behind them, there might be a gang involved or whatever. So the police will take care of all that type stuff. Social services is going to take care of, like, visit the family or the mother, and if they have concerns about the mother responsibility as well, that she's not really safe mother to leave the children with, they will make some arrangements whether these children need to be removed from them, taken to the grandparents or some other, or adoption, or whatever. Social services will look after all that side. School nurse is there, or the school education team is also there, because this child obviously needs to have some support and all that system in school as well, in anonymous way. Okay, so they also see there, and that is called Malak. I will show you my YouTube link, and you can see that how the systems work in the video. Quick questions, just 2 questions, please, if there are any.
Hello,
Yeah.
Dr. Safia. Dr. Mala with you.
Yeah.
Dr. Safia, I have a question. Usually in the rape case, or in this case, as you said, we are taking a sample for gonorrhea and chlamydia later on. My question is that, okay, then how will make the baseline for the patient? Okay, she has right now not, but she is getting this after this incident. If we have no baseline test, so this is question.
Okay, so let's keep the rape separate because that's absolutely different way to deal with from this
Okay,
child
okay,
safeguarding stuff.
okay,
So
okay.
here, the reason to say that we are not going to take chlamydia and gonorrhea at this stage is because it's not possible to take chlamydia and gonorrhea samples at this stage, simply because
Pain.
she's in a lot of pain. And even if there is less pain as well, you don't want to transfer that virus from vulval area into vaginal area. So
Okay.
when I say we will take later, that doesn't mean we're going to leave it for many weeks or for months. The herpes ulcers, they usually, unless they get infected, they usually heal within 5 to 7 days completely. So obviously we're going to take swabs after that. We're going to do the blood test and everything. Yeah. The rape and that is a different, like when we do, and we don't delay their samples either. But they will have first the medical legal sample, but there is their own pathway of SARC, how we do that. And I think in my that video, you will be able to see that as well. What is SARC and referral and how we do them. So yes, they will have the baseline. No, we don't leave them for the window period. You will do the
Okay.
baseline and then you will
Okay.
repeat them after window period as well.
Thank you, Dr. Safia. And one more question means in this patient, we will also take the blood sample for the syphilis, HIV,
Yes,
and
yes,
uh,
yes.
at,
Yeah.
at first contact. At first contact.
We may not do it straight away today
Okay.
because the child is so much traumatized. There is so much else going on. We don't want to add up too much in here to start, for the mother and child may not be able to get an idea about all the potential. But 9-year-old girl usually understand quite a lot. So we start telling them, about the safeguarding, then the police is coming, those people, and then if the mother is there, as the mother obviously is, and then we start, making her worried about HIV and syphilis. My child might have HIV and all that stuff. So it's just normal and natural just to wait for 4 or 5 days. Let's do these things, and when she's healed. But otherwise, if she's okay, yes, we do take the blood test on the same day, even when they routinely come in the clinic as well. Just, there may not be any safeguarding issue. So 14 years, 16 or 21 years old, whoever comes, we may not be able to take swabs for chlamydia and gonorrhea for same day for the reason I have said, because it's painful and we don't want to transmit and shift the virus from one area to other. But we do take the blood test on the same day. Okay, and the reason for that, why we do the blood test is more important as well, because the syphilis presentation has recently changed quite a lot as well. So syphilis does not present anymore with a single painful ulcer. Syphilis is presenting with multiple painful ulcers. So the swab is also taken for syphilis, and the blood test is also taken for syphilis as well. And then many cases we think initially they are herpes, but they come back positive for syphilis. I'm not particularly talking about this particular case, just overall. Okay.
Sorry, Dr.
Hi,
Safia,
Dr.
one more.
Safia. Dr.
For
Safia, I have a question. I'm
Yeah.
Dr. Asya. Uh,
Yeah.
you said now because if patient come in the night, so first we will call our consultant and we will
Mm-hmm.
take just swab for this vesicles or ulcer, and we will
Mm-hmm.
inform the safeguarding in the night, the lead
Yeah.
person.
Yeah.
Because when I in the exam I told I will inform the police, then examiner is very angry. You will inform the police. You will like this. She is too much um, showing that I was very wrong to inform the police. Um, so I don't know. We should inform the police in the night or because she's according to her. Or I don't know. Maybe I did not present nicely, so that's why she is
There may be some other reason.
correcting me.
There might be some other reason, or maybe you need to say that after, the way you will say is like, in this case, we need to inform the police immediately after discussion with safeguarding team. Because what happens sometimes is like they want you to have the appropriate personnel on board, but they can't say the night day is no story here in this country. Okay, there's nothing. If it is required and it's urgent, and it is urgent because we want that victim to be arrested, right?
So
So
for her.
yeah, it's category 1 crime. So we can't leave this and then that person become aware in couple of hours the child has been taken over there and it will be, and then he just escape. So no, there might be some other reason for which their examiner may not have been satisfied.
And in for the consultant pedia, we will inform in the night or they will come in the morning. And
No.
pedia, they will do what examinations? I did not
Okay.
understand.
Okay. So right then. So again, the people who are on call, they are on call. There's no concept of consultant not being called in the night, right? So in this one, you are ringing the consultant because I want to make that consultant aware of this admission and the potential case, a police case, right? So she needs to be aware what is happening with her patient and in her department, okay? Because ultimately she will be responsible. So that's why I'm calling. That consultant, my consultant doesn't need to, your consultant doesn't need to come straight away to see this girl at this stage. She can, I mean, that is what the consultant is actively going to do at this stage. Yeah? The pediatric consultant, again, we want pediatric consultant. You will say, I will inform the consultant. You don't need to think about straight away now or in the morning. But if somebody say, yes, you can't delay them to come in the morning and examine again or do whatever they need to, because this child's care needs to be taken under care. We are admitting her in pediatric ward. Yeah. So we need to ring
Yes,
and inform that
she
consultant.
also asked. She also asked where you will admit, under peds or under
Peds, peds.
OB/GYN.
No,
Peds.
peds, peds. She's peds in the side room. Okay.
Okay, yeah.
Yeah.
And so, okay, so next day we can tell that we can. So next day the procedure is what? Because we will inform, we will do this hepatitis B or serology. We can do in the morning sampling. Or you mean we are going to do morning referral?
No, we can do this swab and the sample straight away now from A&E. Okay, let me just help me to understand first. Um, what is this like concern about the night and the morning? Like, what you
First,
exactly mean?
yeah. First, they said she came in the night, like 11
Yeah,
p.m.
yeah,
So
yeah.
first, because actually I did not properly, so that's why maybe she's very much annoyed, or this
Mm-hmm.
examiner even should responding, because then she said, first of all, to whom you will inform. So
Mm-hmm.
it means now after this all discussion or before also we read that we will inform our senior most person like consultant
Consultant,
and
simple. Yeah,
yeah,
consultant and
inform
safeguarding team.
safeguarding team. Yeah, because that time I said I will inform safeguarding and social worker. Then she said, what is the difference between both? So now, but now I understand because social worker will come at the end when patient will go discharge, or then they will take care at home or keep an eye on the child. But in the beginning, I should not say social worker. So I should say safeguarding team. So
When
then,
you okay, so when we say safeguarding team, their safeguarding team's job, okay, they will give us all the pathway, they will make the referral. Now, when this child, we're not going to send that child if we feel sending back home can be is not safe. If the person, or if we haven't identified, we don't even know who is the person who is causing that. So that's why very next morning the referral will be done to Marak. Come and attend course with me, girls, please. Don't complicate things. They're very simple.
okay,
Watch my video. That will make you a lot clear about things. Okay,
yeah, okay,
the YouTube one. Yeah,
okay, thank
that's
you.
free as well.
Excuse
That's
me,
why.
Dr. Safiya, one simple question. That
Yep.
first of all, that when I'll ask the child about the history, so do you think
Yeah.
we'll talk separately, mother and child separately, or we'll talk together?
So we can't speak to the child separately to start with, because she will just be scared. She's not going to come as a stranger with us to speak, so she may not actually give us. So the general things about what happened, the way when you will re-listen this recording again, general well-being, trying to build up a rapport with her, and all the stuff you will do with the mother present in there. So initially, as I said, like the immediate is get her free of pain, of bladder retention, and so do all that stuff, examination and everything. The history from the mother about when she started this, is it the first time or she had this problem before as well, blah blah blah. That can be done over there as well. When we will come to the discussion about the safeguarding issue, then yes, we will take the mother into different cubicle. So we may not start that conversation straight away in the presence of the child, but we will start. We will ask the child in the beginning. You will ask how that happened. You know, what happened here? You know, why you had
Right, thank you. So next question is swab will take or the forensic medicine they will take
what?
for swab test. Will
Okay.
take or the forensic medicine from the Marat
Okay.
they will take.
So okay, the swab for HSV, herpes simplex virus, will be taken by us. So the forensic one, samples, who needs to take them is, so you know when we said we will inform the police. So when we will inform the police, police then have their own service, integrated service with those people. They're called SARC. Okay,
Sir,
sexual
yes,
assault referral center. They are for
yeah,
adult, they are for children, they are for men as well now. So they
yeah,
do have
yeah,
that department then. So those samples will be taken there, forensic
right.
one, saliva test and all that stuff. Yeah,
Mm-hmm. So they will take you.
yeah. They will take
Yeah,
forensic samples for DNA and stuff. The
yeah,
other the swabs like for chlamydia, gonorrhea, and HSV stuff, we will take them.
right. And then we can that they can the gum clinic they can follow later on. That means after 6 weeks maybe may need repeat to follow up this child. So that then we can refer gum clinic to follow up this
Yeah, we will
result.
involve
Is it?
sexual health team. They're not called GUM
Yeah,
anymore. They're called sexual
yeah,
health teams now. So we will involve
yeah,
sexual health team as well. Yeah.
yeah. Thank you very much.
Dr. Safia, when I told her that I will refer her for sexual health clinic, then she was very angry. She's turning 9 years old girl. You will send to the sexual health clinic.
Yeah. So what we said here is we will involve, we won't refer, we won't send her. Yeah. We have seen her here. We have done the initial swabs. We have admitted her on PEDS, and then we will involve means if she doesn't come back other than her PEDS, she doesn't come back positive with any other infection, then we don't need to even involve them. But when you think or say we are going to refer, think first what we want them to do. So if this girl become positive for some other infection or something else like syphilis, HIV or stuff, then yes, we need their help. If she's not, if she's just like, and the other reason, so either she become positive for those infections like syphilis, HIV, and those which need some long term and more, and we need more input from them. We will involve them, and involve means I'm going to give them a ring and talk to them. Yeah. When you say I'm going to refer means you're going to say, well, I'm taking my hands off from this patient now. Referral means you are transferring care of this patient to other service. Okay. So be
Yeah.
aware of using the terminology. So we won't be referring this child there. No, we will involve. Yeah.
So yeah, so it means for herpes we can just take swab immediately, and for chlamydia, gonorrhea we can delay. I mean, maybe patient will go and not come back. So we can take
No, no,
chlamydia,
no, no.
gonorrhea sample when this night.
Yeah, no. Okay. So what happens here in the, no, again, don't mix with this one particular scenario with the other ones. Yeah. So let's just talk about this particular child here. So this child is going to stay with us, a couple of days. All right. Because of all these other measures to be arranged and everything. Okay. So even if she's not, we are going to put some mechanism in place, no? So that the mother doesn't take and just go this child. We are putting that child's safety at risk. So we're not sending unless we are sure, yes, this mother is sensible, she listen us, she understand us, police is aware, what they know, then this child is not going to go aware. And again, we're not just going to leave it to the mother or the child to say, come back. No, we are going to really put that in system in our recalls. Our social worker will go over there. Our team may go over there and take swabs or sample from the home. So don't worry, this child can't be lost in follow-up. All right?
So
Yeah.
yeah, so it means we can take chlamydia, gonorrhea swab later on, and when it is
So the way
confirmed,
I will say
then
again,
yeah,
the way I will phrase, I will say, I will take this. So we will examine this child for this and take swab for herpes, apply the lidocaine gel or amyla gel we call to make these, obviously for the local anesthetic to make these ulcers numb, and then we will encourage that child to pass urine. And if she couldn't, then we empty the bladder by in and out catheter. After obviously explaining and reassuring to the child. So then depending upon now, if that ulcer or there are a couple of ulcers, just say on the top of the labia majora or somewhere away from the introitus, then we can take swab for, but not maybe straight away because we need to first speak to the child. The pediatrician or us, one of us needs to explain the child why we need to. It's not that, if it's some adult or somebody who's sexually active, for them to say, I'm just going to take some swab from your vagina as well, is different from telling a child, 9-year-old child, I'm going to take swab, or even without telling, trying to take a swab. Okay, so don't be confused about these type of little things in details like now or when or how, right? Simply you need to say, we'll take these swabs, and if obviously this is extensive and it involves intritus, we will delay these swabs for chlamydia and gonorrhea. And you're telling the reason why, yeah, when she's pain-free, because we don't want to transmit the virus from one area to other. And that's fine. That's it. Okay.
Sorry,
Excuse me,
Dr.
Dr.
We
Safia.
Safia.
Okay,
okay.
thank you very much. Thank you very much.
Dr. Safia,
Doc-
catheter who will do?
Okay.
We will do or pediatrician? Catheter. Sorry,
Swabs
Dr. Safia.
for
No, catheter. Catheter who will
swabs.
do? Catheter. Catheter.
We
Is
will
it
do.
by the?
We will do. You are there.
Yeah.
No, it's
Okay,
just
thanks.
in and out catheter in a small little girl. It's just you just need to, we will do it.
Okay, thanks.
Okay. It's just the examination like bimanual speculum or those type of examination. They need to be done pediatrician consultant or by the adolescent gynecologist.
Dr. Safia,
Right.
this is just
Okay.
one question regarding this herpes virus treatment and HIV medicine. So we will tell about that or no?
Right. Well, HIV, don't worry about the HIV in this girl because we don't know at this stage whether she will come back as a HIV or not. All you just need to mention it that we will also take the blood test or screening for the rest of the sexually transmitted infections like chlamydia, gonorrhea, and HIV, syphilis, and after discussion and explanation to the child and out to the mother. So, and for the herpes one, yes, we will say we will start on acyclovir according to pediatric dose. That's all.
Thank you, Dr. Safia.
So we're going to give, so the standard treatment for herpes is we give them amla gel for regular use, so they're pain-free and they can pass urine. We start the treatment with acyclovir, and then we encourage them to have normal salt water bath to keep the area clean to prevent any secondary infection. Okay, so that was a bit of a bit of taster on quality safety improvement things. Then is teaching. Fourth role of a consultant is teaching and supervision, and how we do them. So now the teaching obviously have different categories, and again, for examination point of view, you need to be aware, according to the station, which kind of template of teaching or method of teaching you're going to adopt. So one is formal teaching, which we do. This can be like for that one, we do have a dedicated session or a teaching day or training session booked. It can be in the form of conferences, courses, group discussions, one-to-one, but you have a session for that, yeah? So you just are literally sitting in an office with a group of your trainees or even one trainee to do that. So there, yes, you can follow the template by asking them a bit of well-being and all that stuff. And then if it's about a particular skill they are here to learn, say, for example, neonatal resuscitation or breech delivery or anything, if there is a particular skill, you can start by asking them what you know about this already and what you want to know and what are your expectations from this today. And then you start and they do that. Then obviously there can be again formal teaching reflection on some cases, as we did talk about one of the previous injury cases, or some misdiagnosis or anything. That one is again not only the risk management point of view or risk incidence point of view, this is also part of your learning. Yeah, by doing reflection, basically what we do, again, that's not for any, that doesn't go in any of our record or anywhere other than our own personal note keeping and in our appraisal. That one we do literally totally for our personal learning and improvement, that we retrospectively see that happened. Yes, okay, so then try to think about what went, if I would have done this way, then this could have been done better, or this went wrong, yeah, because I missed this or I did this. So from that one we consciously think what it was, then we consciously register that I need to change my way of practice, and then do this way. And in future, then you say as well, I will show you the template, how reflection is done. Again, there is a standard template for that. And then we also say what change in my practice I'm going to make. Okay, so that's about formal teaching. Then there is a very important part, and the method of teaching is teaching in a clinical environment. So that is the teaching and the training. That is more like a supervision as well. That is teaching on the floor. Yeah, like during when we're doing some surgery, we are telling our colleagues or our juniors at the same time, this is how we should do, this is what we're doing. Or sometimes they come to us um, um, with some patient, they want to have an advisor opinion. They are called by the nurse on the gynae ward or by the midwife on the labor ward to say, this is a pathological CTG, doctors see and what to do. And then she's not quite clear what to do. And then she come to you to say, there are late deserations and these are whatever this is, and I don't really know and have no idea what to do with this. Can you please, help me? No, there are two aspects in that teaching. In that teaching, you can't waste your time by, again, fulfilling that agenda. What you know about the CTG already, and these are the mnemonics we follow, these are the this, and this one, okay, can you now tell me back what you understand? No, what here basically is what is happening, she has come to the patient care take the priority. There is a patient now waiting for to be managed, right? So your priority is to manage the patient first, and at the same time when you are managing, at the same time then tell to your colleague at the same time that this is what we do, this is what we do. Okay, so in these ones, basically, the way there are a couple of scenarios they are putting in the exam to check your this skill. The one is, I think, she comes up with some pathological CTG with some late restorations, and the other one is where your junior come to you and say, I have this woman on triage with pretty high blood pressure, proteinuria, and she's insisting to go home. And then some candidates just literally sit and start teaching them about the preeclampsia, what you know about the preeclampsia and this, and then it's okay, you tell, or this. No, that's not the way. In that way, you're simply going to say to that trainee first to say, thank you for coming to me for the opinion. It's very important. Yes, for something, if you're not clear about what you do, it's very important that you do go to your senior and seek help. So let's go. So you need to act that way, because this is what exactly, again, what I said, this exam is, you need to imagine you are working consultant, you're walking on the floor. Okay, we are recording, you can say. So you need to behave. So what will you do when it's coming? You need to imagine yourself in there, actually on the real floor. You are sitting maybe in the side room or somewhere, your colleague junior has just come to say, she has asked me to see the picture. No, obviously what you're gonna do, you are in your scrubs as well, and you're gonna just, by seeing that CTG with late serrations, you're going to say, yes, I go with you. Actually, we need to see this woman straight away and do that. And on the way, or when you go in, then you will say, on the way you're going to ask her, okay, yes, on this CTG, yeah, but do you want to tell me quickly what you understand, what is happening on this CTG? Okay, but you need to first register that you are aware, you're telling, let's go and see this woman. She needs urgent intervention. And then she will tell, okay, whatever she knows, and you said, yeah, that is, and then you will say, okay, so let's go. So yes, this is this one, our baseline is this high. You don't need to again here go in the basics, that the baseline should be this range and the baseline should be this range, and the accelerations should be 10 to 15 per minute. beats above and sustaining for 15 seconds. No, not like that. Simple. Yes, as you know, the baseline range, normal range is between 110 to 140, and this one is 150, so she has a tachycardia, and then there are no accelerations. And their late decelerations, if you match with the contractions, you can see like the acceleration is starting or finishing after the contraction. So that means we need to actually establish the well-being of this baby. And then you will say, okay, so let's go first and ask the midwives to we need to do fetal blood sampling of this woman. Let's go and ask the midwife to start getting the stuff for that. And we can speak to the woman at the same time what we're doing. And then so what you're doing is actually telling her about the CTJ, telling her about what we're going to do, but then at the same time you're acting there as well. So let's put this patient in the left lateral position meanwhile and start her fluids, and just get there, explain the woman that there are the baby showing signs of distress. We need to, so you're actually telling her the management, that how in future you should go and speak and manage the CTG. This is management of that pathological CTG. Okay, so you will say, okay, so I will go, and then we need to, but the word you will be using instead of I will speak to the woman and counsel, you will be saying we'll go and speak to the woman and explain her, because this baby is showing signs of distress. We need to actually examine her to see how much dilated she is, and then take a small little sample from the skin of the scalp of the baby, and then check for the levels of oxygen and other gases in the baby's blood to see how much reserve this baby have. And this is where you say, okay, so and then you say, okay, so once we take the this fetal blood sampling, then we'll see, depending upon the result, what the pH comes, and if there is this range, we will do this range, we will do this, and repeat, and blah blah. So just a little thing again is the management of CTG instead of teaching pathological CTG, right? So that's about teaching in the clinical environment. The third one is assessment, which Salma was asking initially. There's, again, as a consultant, your very important role as a supervisors, as a trainers. You are supposed to do the assessments even at ST5 level. Again, I do have a video YouTube on my channel. You can go and look into detail about the formative summative assessments, how they are being done. Well, let's just see a little example here. So we said about formal teaching, yeah, reflection in some case. So this is one of the examples, has appeared in exam few times as well. Your SD2 come to you to have a reflect on a case. You have seen one woman who came in the night on A&E and presented with abdominal pain, a little bit of bleeding, and she missed the diagnosis of ectopic for whatever the reason, and sent the patient home. And then she comes later on with a rupture ectopic, and then she has self-injectomy. Patient is same one. So this is like reflection after a few days. She wants to reflect. She wants to learn how different I could have done in that case. Sometimes there may not be anything different you could have done, but you don't know unless you do the the reflection note. It's called learning from your own reflection practice. So in this one, mostly again, in the examination point of view, the main mistake people make is they start kind of interviewing and teaching to this trainee again. They start telling, "Go tell me what happened," and as soon as she tells this happened, then the candidates start telling him, "You should have done this. They do this, and you should have done this, and you need to do this, and then you need to do." So you kind of again start teaching. No, this is it's not teaching. It's learning. Yeah, it's training. It's learning, but it's learning by that that trainee herself. You're just going to facilitate, you're just going to assist. Okay, so on reflection station, you mostly are sitting passive. You are just acknowledging and adding up few points to your reflection. Means we think in a retrospective way. That's what reflection means. Yeah, so it's actually trainees. Main role of speaking here in this is your trainees. So, and how we do it. So first of all, after your bit of introduction, this and this, and then whenever you speak to your trainees and your colleagues, their name will always be given outside in this scenario. When you go in, please don't say, "My name is Dr. Jabin," and you, I mean, what type of team you are, then you do not know the name of your one of trainees with you. Okay, this is dangerous. That probably you know makes you to have some penalty, to be honest. Again, this is not about any clinical theoretical knowledge assessment. This is about you being available, how you can be, you can facilitate your trainings in their learning. And if you don't even know their name, you can see the impact, yeah? So call them by name. Hi, Millie. And usually by the first name. Hi, Millie. I'm Safia, but you just still have to do, I'm Dr. Jabin. So nice meeting you. You can say, yeah, maybe just she's a quite new. It's not always we know them very frankly, but at least I will know, I have given her appointment. I have set up this session with her. So it's just not natural me asking her name straight away in there. What are you called? Millie. Okay, so then you just little bit of a rapport. How are you doing? How long have you been in the unit? Is everything going okay? Give you another opportunity again to check on your trainee that she's not troubled with any issues or any bullying or anything. How are you doing? How you find the colleagues around you? Any issues, anything you're worried about, or anything is bothering you at all? Yeah, and the being in the side, whatever she says, no, I'm fine, everything is fine, everybody's helpful, blah blah, or whatever. Then that's very nice. Right. Okay. So we have set up this session because you want you to reflect one of your cases. So is that right? Yep. And then she will say, yes, I want to discuss. You would have seen the notes. Yes, I have seen. So yeah, okay. You can tell me, first what exactly happened. Okay. So first one is encourage her to give you the description of activity at the event. And then you sit, quiet there. She's going to tell you she came with and this one, and there may be a couple of other things as well, because by now she have thought and see like what was going on. She might add as well, it was really busy shift and this was happening and the ST5 was in theater and this was happening. I couldn't even have my lunch, I couldn't have my dinner or whatever. And then, there was so much busy going on. And then I have a call from A&E as well. This woman came, she was primary gravid, 39 years old, blah, blah. She should give you full, detail of that. Then she came, she presented with this, I did this. And, I thought this, and then I sent her home. At that stage, the only thing you can ask in between is, if say she says she was, she was 8 weeks pregnant, she came in with pain and with the bleeding, and I examined her. Then in between, if you want to say again background information, you can ask, okay, so was that her first pregnancy? So if she says no, second pregnancy, okay, so just quickly about her first pregnancy, was that uneventful? What was that? Yeah, these type of little questions you can ask in between, again for build up, yeah. And then okay, so she started with the pain and bleeding and blah blah. Just again be quiet, passive, just let her finish that. And then at the end, if you think you need to ask her questions, if she says like there was some bleeding, was it heavy bleeding, was she passing class, or you did examination, okay, so just help me to understand, did you, okay. And then she describe this happened. Then you can say, so just a couple of questions you can ask. If you think there is something missing, you would like to know if you're going to give her feedback later on. Yeah, so you can ask, otherwise it's fine. And then again, after they're saying, okay, yes, I can see. When she says it was so busy, it was, it was our manic, it was, I didn't have anything to say. Yeah, well, yeah, there's one thing about ops and gynae is really busy. And it's not unusual sometimes to be so busy that we're not able to eat and drink. Just kind of acknowledge with her to start with. And then you say, so it's fine. No, she described all the events. Then you can just simply say, before what you have learned, before that, I will ask a couple of questions, just like a feedback again. So first of all, I'm going to say, okay, so obviously she's going to, say something. I feel really awful now that I didn't. I'm glad, she's good. And first of all, you will say, okay, so how is the patient doing? If she hasn't told you already, the first one you establish the well-being. Ask, so how is the patient doing now? Okay, so then you can reassure by saying, okay, so that's good. That she returned hospital and she's managed appropriately, so that's quite reassuring. Okay, then because she's quite stressed as well, this person who's there for reflection, you need to help her and again bring her out of the feeling of self-blaming. Otherwise, learning can't happen. Yeah. So we need to encourage her to say, okay, yeah, okay, and it can happen. If there is a clear error she has made, then we'll say, yes, it can happen sometime at time. When we think retrospectively, yes, it's always easy. We can pick up what went wrong and what could have done different. But when we are under stress, pressure, time constraints, sometimes, yes, it can be really difficult. So you're acknowledging in between, and then you will say, okay, so establish patient well-being, and then say, okay, so if she appears again, she says, I'm really worried, I felt so awful, then establish her well-being as well by saying, okay, so are you taking quite a lot of stress of this event? How are you feeling? How are you doing? Sometimes it can be quite serious mistake, and they can be really worried, that trocar person, yeah, or something like that. Otherwise, if she's not particularly stressed, then you don't need to. Then you all need to say, okay, so yeah, good. So tell me first what you feel actually went really well when you saw this patient. There might be a couple of things. You say the examined, I asked this, because that's again pattern. Okay, that's a template, like a feedback. What went well, and then you will ask again. Let her work out what she feel could have been done differently. Okay, this is her own learning from her reflection. You're just assisting, facilitating here. And then she comes in, and then the same way as we do for the feedbacks, in other feedbacks, when she say this went very well, and you say, yes, I actually, yes, yeah, I feel that was really good, that you did recognize this and you did recognize this. You gave that all safety netting instructions to her. You say that happened to call the ambulance or call the hospital, and she actually, did that, and that's good that she arrived hospital at the right time, good time. Okay, and then ask, okay, what do you think could have been done differently? And then listen what she says. I maybe, for example, yeah, I feel like, I was so overwhelmed and so busy, I didn't really concentrate, that I should really do bimanual examination as well, just to exclude whatever cervical motion, tenderness, and that stuff. And then again, let her say all the points she feels could have been done better. Then you say, yeah, I agree. You're right. It's very important. We do know that. With any pregnant women, particularly in first trimester, with the pain. If they have not confirmed intrauterine pregnancy, anybody with abdominal pain is, for us, is to consider ectopic pregnancy. Otherwise, unless it's proven otherwise. So this is, and then you can add up on that. Yes, you could do this, and yeah, we can do this. And after that, then you can just, like before you, what you have learned before that, again, let her, is there any other point she feel could have been done differently? Then you can add up. Then now invite her to say, so what have you learned from this? Okay, so then she will, obviously, she should reflect by saying that, I knew that this is how I should do this examination, I should be, but what I have now seen when I have reflected on that I was really tired. I was, so much stressed. I was not able to eat my lunch and stuff at the right time, and that's why I was not able to focus or concentrate. And the other thing I feel is I didn't speak to the registrar. I didn't inform the registrar about this patient when I was discharging her. I should have, discussed with her. Maybe she may not recognize that point by saying, okay, no, I couldn't, I didn't inform because she was in theater. Then you can add up by saying, yeah, so I know it can be really tricky and difficult when we're working, particularly in these very busy specialties, that we don't get time to eat and drink, but it's equally important. It's very important for us to actually take that break for proper eat and drink, keep ourselves hydrated so that we can concentrate our work. Otherwise, obviously, we become a lot more prone to make mistakes and errors. And sometimes these can be quite serious errors, which can result in life-threatening. Yeah, so it's okay sometimes, even if you're very busy, to tell the colleagues that I need to, take 10 minutes or 15 minutes to eat and drink, and then tell them, your registrar, that you are just going to sit there and eat, so she can take your bleep or answer the bleep. Or if there is a bleep in that time, you can tell them that you're eating. Unless it's emergency, can I come back? Can I come and attend this patient in about 10 minutes? It's okay to say that. It's okay to get help. If your registrar is busy in theater and you think you can't actually ring and discuss this patient with the theater, it's absolutely fine to actually ring the consultant at home and take that advice from there. Yeah. So you actually, what you're doing here is now you're teaching her those different pathways and different things what you should do. It's fine. It's okay to discuss the consultant, or otherwise, if you can't approach any one of those for some reason, it's okay to let the patient wait a little bit more longer and then discuss with the one of your ST5 or consultant before you discharge that patient. So at this level, even being ST5, any patients which we admit or discharge from the care, we always discuss with consultant. You would have seen, even when we take patients to theater for the section or something, we give a ring to the consultants. It's really important that we do discuss, our management plan with our seniors. Okay. And then next up, you say, how is that going to, how are you going to apply this into your future practice now? And then she should come now with one of those things to say, yes, I'm going to make sure that, when I feel I'm really tired and not able to, I'm going to make sure that, yes, I'm confident enough to tell colleagues that I really need 10 minutes out to just, eat, drink, and able to do this work or blah, blah. And then the last step, you will say, okay, what are your next steps? How will the patient benefit? Instead of that, either you can say that one, or you can say how you're going to apply this in your practice. Yeah, the one which I have said, like she should say, I'm going to make these changes. It's very important. There's no purpose of all that exercise if she consciously has not made the plan at the end to say how she's actually going to apply this to her future practice. Yeah. So if I'm just saying, like, if till so it was like, if she get time for eating, that's fine. If not, she will just continue to see the patients, and because this patient needs to go home and hurry or whatever, and if she can't find the senior colleague to discuss, she will send the patient home. Okay, she might have been doing this so far, and it has been going well, but no one thing gone wrong. She must learn that in future she need to inform the registrar any patient she reviews that I'm sending her home or I'm admitting her. Yeah, so she should say that. That's the change. And then you can just at the end close up by saying, okay, yeah, that's fine. Yes, this is important. And then I think it will be a good idea, and I hope you would have done so again, just to just go and refresh the guideline on the management of maybe ectopic pregnancy or whatever that case was. And then in future as well, whenever you see these patients, just discuss the plan. Even if you're very happy that you have done really good management, still discuss that plan, a couple of these patients' plans with your senior, just to make sure that, yeah, you're doing the way it should be done. And then just encourage her to, is there anything I can facilitate you? I can help. Encourage again to her to identify what help she wants. Okay. Third proper way of it's not teaching, it's more of assessment as a role we have as supervisors, as teachers, is to assess our trainees. So the assessments, the way they are done, obviously there are two ways. I mean, there are many different ways, but mostly in your exam it comes as summative conference. But there are different assessment ways as well, like we do CBD, and there are different, those assessments. At some skills they just need to be observed and signed off and stuff. But obviously, all of you are aware the college have their curriculum. According to, you can search that on college site by putting training metrics for our COG trainees, and you will get basically a table, a huge basic table, which actually tells you for every year's competency that they must meet these competencies before they will move to the next year of training. And that will help you to also understand what different STs can do. And so obviously they are given that plan that, say, for example, by the end of ST2 year, they should be able to, for example, they should be able to take fetal blood sampling independently and interpret the management of, the pathological CTGs. I'm not saying this is what exactly the curriculum is. I haven't seen it for some time. Obviously, we can always pull out. I'm just giving an example. So, but then obviously they need to get that assessed. The trainers need to do that assessment to make sure, yes, they have achieved that competency, and if not, why not, and what can be done to facilitate it. So it's not only trainees' responsibility. that they have to, attain and satisfy these certain criteria of their assessment for their progress. It's equally the responsibility of the supervisor, trainer, and also the clinical tutor. There can be different reasons. Sometimes some trainees are not getting enough opportunity to do things. They're not getting theater list. They are rostered to go for theater list, but then some colleague has gone off sick, and just at the morning they are pulled out again to say, can you please come and cover the labor ward? So they just not getting enough opportunity to do things they should do to attain their certain. So there needs to be identified, right? They need to be assisted. Then they need to be supported. How that can be achieved. So that's why these assessments are important. Summative assessment is always something you can call like the final assessment, where basically those colleagues, the trainees feel they are now competent enough to do that particular procedure or particular skill, they can perform independently, and they are happy to be assessed on that. That is called summative final assessment, you can say. The formative is before obviously you reach to the summative or the ability, what is the usual pattern of learning any skill? What happens? The first step of that is observation. You observe other people doing that particular procedure or skill. Then the next one is that you will do and let them observe directly. The third one is you will say, well, I'm okay. Say, for example, episode me. I'm fine to do this episode me, but can you please be available in case if I have any problem? Yeah, this is called indirect supervision. And then I will say, okay, no, that's fine. I'm just sitting on the, whatever that midwife station writing the notes. So I'm here, if any problems, just give me a shout. So that means she might just call me at the end to say, Dr. Jabin, can you come and just have a look to make sure that, yes, I have secured the apex and I have done proper, whatever, yeah? So there's indirect supervision, where I might not be just literally standing on her head and telling, take this suture from there to there and this stitch from there to there. So this is indirect, when you are just around available. And then there is independent, means I don't need to worry. You're on call. I'm just at home or in my office, and you can just give me a ring and say, this is what the CTG was. I have done fetal blood sampling. This is pH, blah, blah, blah. I need to take this patient to theater. And because from your previous assessments and observations and everything, I know by this time that, yes, you have the skill basically, and I'm satisfied that you can interpret and take the right decision. And then if you feel that this was fetal blood sampling, and then I know you are able to do this particular cesarean, say second stage cesarean, because I have assessed you already, I will say, yeah, that's fine. Go ahead with that cesarean. So that's why it is important. Okay. So for any competencies, say for example, you can say, take an example of, let's take an example of maybe episiotomy. One of these are coming in the exam as well. Somebody wants to have this ST1 or ST2, whatever the level is, they want to get this one. So what they need to do is, first, in the same way, they need to observe few, and even for that one, they need to keep a log, okay, that they have observed these many procedures. And in some competencies, it's even defined. You have to observe, say, 5 procedures or 2 procedures, and then you have to perform 2 under direct supervision, and then you have to do, yeah. In some it may not be. So formative is one of those assessments where the trainee feels now, he has started feeling that actually I have done all those steps of observation, direct supervision, indirect supervision stuff, and actually no, I feel I can do them independent. Okay, so you are just with me, and you were called by the midwife, and it's a second stage fully dilated lady, headed +2. Outlet forceps, you are not still fully competent to do outlet forceps, or somewhere in the middle of the training, and I happen to be there as well. I come and say, yeah, that's fine. Emily, you do this, outlet forceps. I'm just watching you. So I'm there. You can say maybe this is the direct supervision of her forceps delivery. Okay, so she does that one, blah blah, give an episode me, and then she says, well, Dr. Jameen, when you happen to be here, will you be happy to just observe and give me formative, assessment on the suturing of episiotomy? And if it's not running really mad, busy, then I might say, yeah, that's okay, I'm happy. All right. So for the formative one, you can inform the assessor just before you start that procedure to say, would you be happy to assess me for this formative, right? And then I will stay there and observe you what you're doing. At any stage, if I feel, no, you're not doing, you have not done the way you scored the episiotomy, you could do stage, you have taken too deep stage, that could result in later some, fistula, blah, blah, X, Y, Z. I can, give you there as well. But at the end, I can say as a formative, if I'm happy that, yeah, actually you were fine, except a little bit thing, it may not be anything, and it was excellent. I might clap for you at the end, but it's still formative. Okay, so the forms, they are same for summative and for the formative. Okay, all sets, all of you would have seen these forms. Again, they are present at the RCG website. Let's see if I can enlarge it. Come on, doesn't want to. Anyway, so it's kind of tiny here, but you can have these forms on the website to say. So on the top here, it says trainee's name, trainer's name, procedure name, obviously, clinical difficulty, details of the complexity. It was a simple state for short episiotomy, extended episiotomy. Yeah, so you describe that difficulty here, degree of difficulty. Okay, so this one says encounter requested in advance. This is for summative. You need to, do. But the formative one, you don't need to have in advance, but advance at the point as well. You can't just do like I happen to be there and I'm talking to the lovely midwife, and then you are just doing the episiotomy. And I'm just actually happen to stand behind you talking to the midwife and chatting with the patient as well. You've done excellent, and in between I would just happen to have a look, and then I say, well, that's very good. You did really good episiotomy. You say, okay, in that case, thank you very much. Can you sign this formative assessment for me? No. Okay, so although I'm happy, but you need to tell me beforehand, before you were starting this procedure. So you need to say, okay, when you are here, if I do this, can you please observe me? Because then I need to be in that mind. You also need to be in that mind. And the other main important skill, which is you need to be trained, is working under stress. Yeah, when you know we are being observed, that put a little bit stress on us. Yeah, you might be different than doing independently and yourself, nobody watching, and then it happens to be very nice. So you need to tell me before you start. And then the feedback we give needs to be very objective feedback as well. So I just can't simply say, oh, that was lovely, you did so beautifully. No, I need to again open that on there to see. On the top here, I think it says checking the equipment and perioperative, planning or technical ability and all that. So you need to individually give remarks on those individual skills. This one is again to make sure it's an objective and proper assessment. It's not just subjective, everybody's different. For somebody, I will say overall that's fine, and somebody is like very careful about the tissue handling and everything. For me, that may not be good. So some people are. I just personally like that particular training from her mannerism and from all other different things. So it's very natural as a human beings. We do incline to like some people around us, and I might just say, yeah, that's fine, absolutely. I'm happy. I'm signing you off. So that's a subjective. That's my personal choice. That also put pressure on the trainees if we do that way, because they might think, well, she needs to really keep this consultant pleased, because if that particular consultant is unhappy, she can't mess with my assessments. Okay, but if I have to do this way, I have to individually give the comments. I can't either just simply favor to somebody if I want to by just saying excellently sutured episiotomy, or just saying she didn't do. I have to then be specifically tell why I feel is not good. Okay, so that's why you have to answer according to this. And then your feedback is again in the same way: what went well, what could have been done differently, and learning plan. And then if you feel, yes, that's fine, it was done according to, then here you can see there are two options here to sign. The trainee performed the observed procedure competently, or they need working towards the training. Okay, so even for formative one, if I feel she has done, I will delete this across this, and then I will sign, and the trainee will sign as well. We need to agree on that discussion and on these remarks. Okay, on these remarks. Yeah, so, and if I feel no, she should further work on that, then I will keep this much she's working towards the competency. So that's the formative one. For the summative, the assessment, observation, feedback, comment will be same. The only thing needs to happen in that one is you can't just simply on the day just before the procedure decide and tell me I'm going to do that. Will you observe me and give me the feedback? That must be arranged pre-hand. Usually that's done on elective list of procedures, and even when we are on the maybe on the emergency on call, maybe you can ask me like I really need to get signed up for second stage. So if I'm with you and this one you are covering. So if we have to do any cesarean, will you be happy basically to do my summative assessment? So we will agree. I will enter into the diary, okay, and that my on call, we will be doing this. Yeah. So that needs to be in advance date and time. And again, just maybe if I'm doing the formative one, you just started, I happen to be just on the floor. Maybe I have come down to see the patient with PPH or preeclampsia or something, and then you had this lady to a failed instrumental trial, and then that one, and then just before that you say to me, um, can you observe me? Or I'm just simply, you say nothing. I'm just, there with you, watching you to do or assisting even, or maybe, and then if everything goes excellent, you say, can you please sign my summative assessment? No, I won't. That needs to be then. Okay, so that is one important point, that it must be agreed beforehand. For summative, before summative, you need to have 3-4 formative assessments to be completed. And those formative, all of those 4-5 doesn't necessarily have to be signed up fully as a, the trainee is, has done the procedure competently. 1 or 2 may be working towards the competency. Okay, that can be false. There shouldn't be a fear on the trainees. So if there is 1 or 2 of that one, that's fine. And even if she has done, first 2, she doesn't want to put them in, okay, the last 4, 5, she has performed competently, that's fine. But we do encourage, we like to see if there was any mark where they said it wasn't done competently, that to be the part of as well, because that actually reflects your learning. That yes, you took that constructive feedback and you learned, and then you have, attained your skill. Now, what very rarely some issue arises is that we have done this assessment, and for some reason, it's summative assessment, say, for example, analysis summative is the one where some conflict can arise. So say, for example, we take that episiotomy suturing, the candidate has done the suturing, and she asked me to do whether it was summative assessment. Yeah, it was agreed. Okay, that's fine. She did. But she couldn't skewer, again, one of the recalls, she couldn't skewer the apex nicely. The patient was bleeding, and she couldn't actually identify either that she was not able to do that. And I'm not really, I feel she still should continue to work towards the competency. So I tell her, and she says, no, I have done that nicely. I don't agree with that. I have done that competently. Well, but that needs a little bit more improvement. And then she goes, no, because there was no proper position. The patient was not doing, she was not giving me proper exposure or whatever, or the light was not appropriate. But I have done, still I scored, that bleeding. I did it myself. But obviously it's not done the way it should be. Yeah. So first I'm going to just take it as a simple way by saying, okay, so because of these reasons, it's very important, this and this, and that I'm not satisfied, or I feel, usually we don't say I'm not satisfied, we just say I feel you still need to practice few more, and get, and then have your summative assessment. The trainee still goes again, whatever the reasons she or he gives, and say, no, I'm not. Then I'm going to know I need to follow certain pathway now with this trainee, because there is a conflict now. Okay. So there's a conflict now. I feel she's not competent to do independently yet, but she feels she is. Okay. So now I'm going to take that pathway. The first step of that pathway is I ask her to say, tell her by saying, I can see you want this to be completed today, this massive assessment. However, equally, on the other side, I feel it's very important. No, I will become a little bit assertive, and I will say it's very important, as a trainer for me, it's very important that you do meet all the criteria of assessment of safety, of your time management, equipment handling, or whatever, and then I can go back again. Obviously there is something lacking here, on which basis I'm saying. So I will say, because this is not meeting that criteria, I'm really sorry, I can't. I don't agree that, I can, and then I need to ask her. Then I will ask. So, is there anything you're worried or bothered about? Why are you feeling so stressed that you must get this signed off completely today? Yeah, so first I need to explore. It may be that she actually is already given the 6 months extra as an extension of 3 months to meet her competencies of this year training. So she was, for example, from ST1 to ST2, she was supposed to go. She couldn't meet her all the competencies, so we did extension of 3 months already. You say, okay, you do these in 3 months. So maybe she has some stress like that going on. Or maybe she come up with by saying, well, I don't get to do these episotomies, I hardly get any. So if I didn't do it today, it might just take another month or so before I will have the chance to do any others. Yeah, so then I need to identify what exactly is going on. And if that is, then I need to support and sort it out for her. I can't just simply tell her, okay, no, I'm not, and then go away. No, then I need to, as a supervisor, put something, maybe increase her rota to labor ward more, or tell her the other, whenever she's on the call, to registrar or whoever, or the midwife even who can do the episotomies, all of them, that the Emily needs to get this signed. She needs to do a few more procedures in episotomy. So please, when she's on call, give her maximum opportunity. Just give her a call to see if she can come down and do it. Okay. So this is how we find out. So this will be my next step, to explore her and find. And if she's still not, she's just that person is just adamant. No, I don't want to. I am. I don't see any reason why you can't do it. And then I will say, okay, I'm like, again, the next step will be, I will say, I can see you're frustrated. I'm here to help and support with all this. And I really want you to, understand my responsibility as a trainer and supervisor. That is my priority, to make sure that the person I'm going to sign off, that the person is really competent, and that person can do the procedure, with full safety, without compromising the safety of the patient care. Okay, so that's my a bit more assertive, and a little bit of more, coming to the formal side now, to tell her that she needs to recognize this. I do have the reasons why I'm saying it. Okay, and then if she still is not, then my next step is, okay, that's absolutely okay. If you feel, I have explained you, I have told you, I have offered you all this support and every blah blah. If you still feel that you have the conflict, you are not agreeing with what my decision is, we can take it to conflict resolution. And the conflict resolution is basically, I will just give her an option to say, you can get this procedure assessed by somebody else. Otherwise, I'm happy to arrange another one assessment for you, and I might just set up the date and time as well. Say on this date and time, I'm fine, I'm happy to actually do you. Then, and meanwhile, if you want me to actually again show you and tell you how to do it and show you one to observe and blah blah, I'm happy to do that. And if it's not, then I will say, okay, that's fine. I can't, and you can take it to somebody else. Then for that one though, there will be a note we will be writing, and then sending it to the clinical tutor. Okay. And that's all. I hope you all got good idea now about different aspects.
Dr. Sophia,
Mm-hmm.
how are you?
I'm very well, Simon. Thank you.
No,
How are you?
fine, alhamdulillah. Just in this scenario, the trainer after the examiner or the ST5 tell her like this, she appear another paper by formatted assessment, and she told her just sign this one to me. So what it will be the response also?
So she came for the formative, but then she
She
says
came
sign it as a
no, she came for summative, but after the examiner tell her no, we cannot because you didn't take the apex well and you didn't meet the criteria. She appeared the formative and she told, okay, so sign the formative for me.
Yeah, we can do that for, because that's what the formative assessment is. Yeah, so after that discussion and needs to improve whatever was required, and here we write down the trainee is working towards competency. So when we sign this, then it will be taken, she can keep it as a formative. All right. So then we're still going to sign this bit here and delete the top. And we can say, yes, you can't keep that in your record as a formative.
Dr. Satya, they can sign it summative also with the remark he didn't do the apex properly.
Sorry. How we make the point that that person didn't do the apex properly?
There is a no space to write
Yeah. So
in
that's
the
according to,
remarks.
yeah. So that
In the
will be,
remarks.
yeah, in the remarks, I tell you where. So on the top of this, I don't know why I'm not able to enlarge it. It was doing yesterday. Screen anyway. So on here you can see there are a few steps here. Yeah, tissue handling, completion of task as appropriate. So when I'm talking about all these forward planning, dealing with documentation, safety concerns, so I will deal here. Yeah, tissue handling. So tissue handling is like, was she like maintaining nicely the suture strength and the way she was taking the stitches, everything, and then completion of task as appropriate. So then I will say no, and then where I can, what went well and what could have gone better. Here, I will add what she feels, but then I will also add what I feel. So I will say, the apex was not, and she bled and blah, blah, and this could have been done better. So one, I'm going to tick over here, completion of task appropriately. I will say no, not achieved. Yeah, I will say not achieved. And then I will write my note over here to say, what could have done better, yeah, to improve. So for the points needs to be improved will be documented here. What went well, and then I can add, she can tell me first, and then I can add by saying, yes, that doesn't mean she has failed all these points here. But then I need to see which one. If so, say for example, she might have a selection of instruments. She may not have chosen the right instrument, or economy of movement. She might have taken a bit longer. But then I will see, okay, if it wasn't too late that even a little losing was causing, I might just simply say to her that, you need to, you're a bit slow to do that. She said, well, the patient wasn't really relaxed and she wasn't giving good exposure and the legs. And I will say, well, you could do proper, then you need to, have a good light and maybe you could give some more analgesia. Yeah. But it wasn't too slow, then I still might be fine to sign her. I might just still say needs improving and give a little comment here just to mention this now. But if it was too slow, even that one can make me to know she needs to, if she's saying the reason she's giving to me took too long, from which I think from the technical difficulty of this episode was, if she still took too long, and the reason she gives is patient was not, cooperating, and what she did about that then? Did she address the analgesia? Did she, did she say it's not happening? Or did she ask some assistant to come and give some exposure? Yeah, use of assistance. Bring other light maybe from theater or something so that I can have a better exposure. Yeah, so it's about all the awareness. So if she have done a little bit slow, but actually she did address at that stage when I was watching, she said to midwife or somebody, or even to me, can you please help me with this? And or she checked with the patient if patient was pushing away or whatever. Is it painful? I give you a bit more local anesthetic maybe, or shall we, top up your epidural? So as long as she's aware that she's doing what she needs to do, then even if she done a little bit slow, I might still be happy to sign her up. But then if she doesn't recognize then so it's like objective, yeah? So it will be according to these points here. What I'm not satisfied, I will do, and then in the comment, I will write up here. Okay, so that's all now.
Dr. Safia,
Yeah.
you said that if a patient came for this trainee came for this summative, and if she's not competent, so we can, and if she will say we will, can you sign for formative? We can sign, but whatever we read till now, we cannot change. Whatever she want, it should be clear from the start. Either it is for formative or for summative. It cannot be changed.
Yeah. So when she wants formative one, this was for the formative. Then I told you like she needs to tell me before the procedure. Yeah.
Yeah.
So the other way you need to think, I don't know who told you and how much aware they are, but obviously I am assessor, I know. So say this summative one. let me go back on that submitted page. Okay, and the submitted one. Here there are two columns here. Yeah, one is to say this trainee performed this observed procedure competently. Another one is she's working towards the competency. When I'm not signing off this on the submitted, when I'm signing the trainee is working towards competency in this procedure, that itself becomes formative. Okay,
Yeah.
it itself
So we
becomes
can comment
formative.
here.
Yeah, we can say, okay, this one is, and then yes, by all means, you can keep that in your record as your, formative
She's
means
working.
informing. No, what formative means? Formative means informing assessment to that trainee, basically.
Mm-hmm.
What you're doing well, what you're not, what you need to improve. Okay. And that one
Yeah.
is for just like, so when you will take this part 3 exam, the final day of examination will be your summative. But before that, when you present the cases, so you're doing the course with me, and in the course I say, okay, Asya, you're going to present this case, and you then present that case to me. Then I give you the feedback. I tell you what you did well, and then I tell you what you need to improve. That is your formative assessment.
Yeah.
Yeah,
Yes.
because that then
Yeah.
helps you to assess, yes, these aspects are good, I need to improve on this one. And then I have told you the tips as well on that. Yeah, so I have then given you the resources and guidance how you need to improve it. So I'm going to support you. That is formative. This is how exactly the formative assessments for the skills work for the trainees. Okay. So yes,
Yeah.
if
Yes.
it's not submitted, you just basically need to reassure that person saying that when I have done this work as a formative, but before she actually have asked me to do this, she has done 3, 4, or 4, 5 formative already anyway, and she can put that as well there. And as that, we do encourage people, we do encourage our trainees to include those formative this assessment one which says trainees working towards competency. We don't want them to, she has done say 3 or 4 formative, and out of them 2 were saying still needs to working towards competency, and the 2, and then she keep doing 10, 11 formative because she want to present R 4 or 5 to me, which all says she's competent to do that. Right? I'm happy. I will actually be rather happy to see 1 or 2 which says work towards the competency, because then I know, yes, you did the assessment. You basically have active input of your assessment to see what I need to improve. You learn from that and you have improved it. So that actually gives you more benefit. Okay.
Yeah.
So yes.
And also,
Yeah. Mhm.
and in the scenario, if mentioned that notes there that patient did not this take the apex. So it means I don't know that I am the one I supervised her, or maybe this is for me in the.
Sorry, Asya, I didn't quite get your point. There was some interruption. So you want to say it again?
Because in the exam mentioned there is the notes that she did summative, and this tip she missed. So I mean, I don't know that I'm the one I supervised her, or someone else supervised.
So yeah, you are the one. If it's a formative or summative, if you are doing that, that means you have watched that. Yeah. So unless you have observed it yourself, obviously you can't give the feedback. You can't assess.
Okay.
So in this
Okay.
scenario, when it says you are there basically to do her formative or summative, then you are the person who has observed her.
Okay. Actually, it is not mentioned clearly that I have observed, but you mean if she came for me for summative assessment, so it means this is I'm the one who observed, and I am the one I picked this
Yeah.
points.
You probably
Yeah.
didn't quite well hear in the beginning, Asya. What we said was, no, actually, the trainee has come to me for the summative or the formative feedback or the assessment. We said that will be like beforehand, it will be agreed, both of them, even formative one, right? So obviously, she won't be asking me to sign formative if I haven't observed. And if they are putting that way, if the scenario is not saying scenario, just simply say she did that procedure with some other, ST5 or ST3, but that ST5 or 3 could not sign off that assessment that day for her. And the trainee now come to you and say, I did excellent. She was happy for me. And she said she will actually sign me up for summative. Well, summative can't be because summative is always a dedicated session. So the formative one, but then there was an emergency. She went to see that. And then now she's gone on sickness leave for so long. Can you sign it for me? If that's the scenario, then I know somebody else observed. I don't know what they assessed at that stage. Then I'm going to say, I'm sorry, I can't do that, because I do not know what was assessed and how it was assessed and what criteria it was assessed. I'm happy to you to actually, perform the procedure. Let me know beforehand. I will assess you, and then I will be happy to complete this assessment for you. All right. But otherwise,
Okay,
if the
then.
scenario says this is the patient and you're supposed to do formative one, then obviously it's you who have observed their procedure.
Okay.
You can't do the
Basically, these
assessment.
are recalls. Yeah, so we don't know what is exactly mentioned.
All right.
So that's
Okay.
it sometimes. Okay,
Okay.
thank you.
Okay, that's fine then. So let me close up
Excuse me.
here. So
Excuse me, Dr. Safia, please.
yeah.
Yeah. So what I asked you before, that means before starting the procedure, so how much summative process need to be signed by the consultant? Is it 3 or 2, or it can be signed the ST6 or ST7, or only the
Okay.
consultant? Please.
Okay, so the
Thanks.
formative ones do not need to be necessarily signed by the consultants. There is no range definition that this month should be done ST4 and this month by ST5 or ST3. Anybody who herself or themselves have been signed off as a competent to do their procedure, they can do formative assessment with you. But the way trainees do, they usually try to do one or two with some consultants as well. But even if it's not, as long as it's even ST4 or ST5, who themselves have been signed off for that competency, they can do the formative assessment. Summative assessment preferably needs to be done by the supervisors or by some consultant. Okay.
Yes. So how many summative by the consultant? How many need to be signed
Okay, as I said, like
before?
for the formative one, there is no criteria how many. Overall,
No,
there
some.
need to be 4 or 5 formative ones, and they can be done by anybody. If you have a lot of consultant around you and you get opportunity to work with the consultants most of the time, that's fine. You can get for all 5 of them signed by consultant, but that's almost impossible here in this country. So you can get it by ST5, ST4, ST6, ST7. There is no definite criteria that it should be this level. Anybody who herself is signed off, then obviously it can't be ST2 of your own level, right? It needs to be somebody senior who have done that competency already. So ST4 or ST5 maybe. Okay.
Sorry, I'm asking about the summative, not formative. Summative before uh, starting the procedure. How many need to be signed?
Summative is only one. Summative will be done only one assessment. And that
Only
needs to
one
be done.
assessment then.
Yeah,
Okay.
summative is final assessment. Just as I have given the example, you can do as many training courses, you can present as many cases in your these courses. They're all formative. You will have the feedback, you will improve. But the summative is only one, yeah, the MRCG
Mm-hmm.
final exam. So at that day, either you satisfy the criteria or you don't satisfy the criteria. And if you don't satisfy the criteria, it kind of become your formative again, because then you get that feedback which tells you what you need to improve and what you did not satisfy. Okay. So then you
Mm-hmm.
try again to improve those particular aspects, and then you again take the time and date. Yeah. You book your summative by advance date and time, and then you go for your summative again. And if you pass,
Mm-hmm.
if you get dissatisfied first time, you done it. So summative is only one. That's the final assessment, you can say. After that, you are able to do independently.
Yeah. So
Okay, so
summative should be. Sorry,
yeah,
summative should be by the consultant or supervisor.
yeah, yeah,
Yeah. Thank you
by
very
the
much.
supervisor. So this is our YouTube channel. So MRCG Overseas. It should look something like that. Go and subscribe. I hope you all know by now how to subscribe these channels. Um, anyway. In Google, you can put YouTube and go to YouTube and then just in search one, put MRCG Overseas. You will get this is how our channel look like. there will be something here in red say subscription. Please press there to subscribe and then put this bell icon as well, and there will be given notification one. The benefit of doing that is whenever I put any new recording, you will be able to get the alerts. There are quite few already. Some tricky questions of MRCG. Again, there are some recalls, how to complete OSATs. All these discussions, you're asking me questions that have been done really in good detail there. Clinical audit has been done. And there are a few common things why people fail as well. I mean, it's your choice, but there are a few now, and these sessions will go on there as well. So please do subscribe, and you can see them. Are those SARC and Marak and safeguarding? They all are given in those videos as well. Okay, so that's for all. Thank you very much. Bye now.
Thank you, Dr. Safia. It is very nice session.
You're
We enjoyed.
welcome. Thank you. Thank you. Bye.